Advanced Nailing Webinar Episode 1 this is, and the background of this is formed by IOA. I'll request Dr. Gadegone to brief about this committee and the schedules in front.
Good morning to everybody, viewers of Artho TV, viewers of IOA TV, and all delegates all over India and abroad. Respected Shrivastava sir, Chaddha sir, President-elect, Vice President Atul Agrawal, and Secretary Naveen Thakkar, and Academic Chairman Dr. Vivek Trikha, and my colleagues, Dr. Santosh Singh, and respected Dr.B.Shivashankar, a past President of IOA, and all faculty members. We are planning a 4 to 5 webinars for a difficult part of the nailing, or upper extremity, lower extremity, and also a regional. This will be a platform to learn for all young surgeons all over India and abroad. And we are planning a very good program in coming months in the April, May, June, and July. So viewers, you are all welcome. And those who are interested, they can interact with the faculty members, those who are present here and deliberating their knowledge. So welcome all, and welcome all faculty, those who have given me a chance to celebrate, we can say, this difficult nailing webinar. So I handed over to Dr. Santosh Singh. He will introduce all faculty members of this present webinar.
Thank you, Dr. Wasudeo Gadegone, sir, the chairman of the IOA NAILS Committee. And I have a privilege to introduce to the learned speakers, and I think all speakers don't need any introduction further, but for the new surgeons. The first talk will be by Dr. Ajith Kumar from Bangalore, the Reaming principle in the complex fracture. So I think it will be better to start one by one and introduce before their topics. So may I proceed to Dr. Ajith Kumar?
Yes, sir, please.
Dr. Ajith Kumar, welcome, sir.
Thank you, sir. Good morning, and grateful to the IOA NAILS Committee for giving me this opportunity. My talk is going to be on reaming, intramedullary reaming in difficult fractures. So I'll start off with the concept of why reaming at all, and then go on to a few situations. There will be some overlap because we're talking about all patterns and all varieties of fractures here. So I will just give a brief outline about the pathophysiology of reaming and some ideas about reamed versus non-reamed nailings. So as we all know, the father of intramedullary nailing is Gerhard Kunscher from Germany. And he had a lot of designs and implants right from the 1930s. And most of the current concepts take their origin from this great surgeon. So in those days itself, he had used flexible reamers to get a tight fit of his cloverleaf type of nails, so that there would be better stability of the implant. So somewhere in the middle, the concept of using unreamed nails came in because of certain perceived disadvantages of reamed nailing. And the thought process was that unreamed nails would cause less blood loss. There would be less risk of embolism, and in turn, less risk of acute respiratory distress syndrome, and also mainly less disruption of the intraosseous vascularity. So these were the concepts, and for a time period, unreamed nails became popular. However, they had certain disadvantages which we might discuss here. So because these were unreamed, it was difficult to insert. You needed to plan preoperatively because the canal diameter was of critical importance. If it was too small, then it would be unstable. If it was too big, then you would get stuck with nail incarceration. So these were problems. And also the incidence of non-unions and breakages of the implants, particularly the locking bolts, were much higher in this nails. So all of us know that the benefits of reaming include the enlargement of the canal so that you get a bigger size, a slightly bigger size of nail with a good nail to bone contact, a decrease in the working length, and obviously a better stability when you use a bigger size nail. So these are the advantages of reaming. Also, there are biological advantages that the reaming products act as internal bone graft, and so it does help in the healing process. However, there are certain disadvantages with reaming. We all know that the endosteal supply gets disrupted, although transiently. Studies have shown that it is restored within about 4 to 6 weeks. The risk of fat embolization is there, and we'll come to specific situations later. The problems of thermal necrosis has been talked about and discussed in the earlier days. And also the causes of fat embolism and ARDS with particularly patients with chest injuries is definitely one of concern. Way back in the 70s itself, Trikha and others had shown us that reaming causes disruption of the endosteal blood supply. However, at the same time, there is an enormous increase in the periosteal blood supply, almost a 6-fold increase in the periosteal blood supply. And although transiently there is a decrease or damage to the endosteal blood supply, particularly in the femur, the healing process goes on uninterrupted. So, coming to certain studies, reaming causes tremendous increases in the intraosseous temperatures, and it varies with the amount of force that is used, amount of reaming speed that is used, and also the size of the reamers that it is used. So these are micro histopathological pictures of the endosteal damage that is caused by reaming. So the other concern in reaming is the pressure increases that occur with this. Normally in the intraosseous pressure is about 30 to 60. The resting pressure is about 30 to 60 millimeters of mercury. But when you open the medullary canal, it shoots up almost 3 to 4 folds. And even the guide wire, when you introduce, there is a tremendous increase in the intraosseous pressures. And reaming also, the first reamer causes the maximum increase in pressures. Subsequent reamers do not actually cause that much of an increase. However, the nail insertion can cause, whether it is unreamed or a reamed nail, there is a tremendous increase in the intraosseous pressure. So we need to be careful about how we do it. Now, the type of reamer also has a bearing on the complications that can be encountered. So to minimize the adverse effects, one should not use a tourniquet, and ideally you should have sharp and deep-rooted reamers, preferably front cutting, and then small increments of 0.5 millimeter diameter increases would be optimal. Many systems have a 1 millimeter increase, but ideally a 0.5 millimeter increase would be ideal. So sharp reamers, small increments in diameter, and no tourniquet. These are critical in having a good outcome. So these are all the pressure readings when you actually ream. So the suggestions are that you ream at full speed, but you advance slowly. And all the time you keep going in and out. Withdraw the reamer intermittently so that the heat generation is less. Otherwise, when you get stuck, there is tremendous increase in the heat, that is intramedullary heat that is generated. So blunt reamer causes more than 2 to 3 times the increase in the heat that is produced in the intramedullary pressures. And here's one example that the devastating effect of thermal necrosis that has occurred in this particular patient. As you can see, the entire diaphysis has been affected by over enthusiastic reaming. So this is one complication that we need to keep in mind. However low the incidence may be, this is something that we need to keep in mind. So coming to the complex fractures, the reaming in complex fractures, what are these complex fractures? So it could be segmental fractures, comminuted fractures, open fractures, a polytraumatized patient, pathological fractures, and also the main concern, a patient with chest injury. So coming to the segmental fractures, we always worry about the mid segment. What happens to that when you are reaming? So either you hold it with a clamp or a pointed reduction clamp, or you gently pass it with pressure, not too much of reaming, what you call minimal pressure reaming, and you push it across. If the canal is tight, definitely you need to hold the mid segment while you're reaming. So there will be cases shown later in the other talk, so I will not dwell in depth, but you push through the intermediate segment, or you hold that segment and ream gradually if it is a tight canal and you need to pass an appropriate size nail, because we know that one of the fractures will definitely go in for delayed union in a segmental fracture. So you need an optimal fit for the nail in this situation. So here's an example of how to hold the fragment while you're reaming. Coming to comminuted fractures, ideally there would be a lot of soft tissue damage also in this situation. So just push it across that comminuted area, or there is something, the low pressure reaming is also acceptable. But generally, when there is such a blowout sort of a situation, the reamer goes in easily without one having to ream through. You can just push it down the comminuted area. So hence, the diameter is not a major issue. The diameter may be an issue proximal or distal to the comminuted area. So very carefully, you push the reamer across such an area. The reaming also depends, the pressure of reaming also depends how comminuted it is. Severely disrupted or dislocated fractures, the pressures are much less because there is dissociation or disruption of the pressures. As you can see, there is high pressure when in an intact sheath is there. But if it is comminuted, this high pressure area is very, very minimal. So that's one of the things that we need to keep in mind. What about pathological fractures? A lot of worries are there about pathological fractures. Many series have published higher incidence of pulmonary embolism or even cardiac arrest perioperatively. There are some publications where there is a high incidence, but in Pieter Gionides' series of almost 30 cases, there were no problems. But the important thing is, since these people have a limited lifespan, you don't have to ream to the very maximum to get a very, very thick nail. You could, up to the point where some sort of minimal chattering occurs, you stop the reaming and put on an appropriate size nail, so that the whole aim of this surgery in pathological fractures is improving the quality of life. It is not the longevity or the union of the fracture. It is improving the quality of life. So one need not go in for the largest diameter of nail in such situations. So hence, what has been suggested is reduce pressure reaming in this, and which reduces the chances of embolization due to pathological tissue in these sort of situations. So what are the conclusions? In infection, whether it is closed or open fractures, no difference between reamed and unreamed nails. We are not talking about the extremely contaminated nails here, situations here, like a farmyard injury. But type, say up to 3A, there's no significant difference between reamed versus unreamed nails. And reamed nails are better as regards time to union, non-unions, and reoperation rates. Thoracic injury is one major determinant of pulmonary complications. and it is not whether you ream or not. If there is lung contusion, if there is lung tissue damage, lung parenchymal damage, then one should not proceed with ream nailing. You do damage control in that scenario, and then later on undertake the definitive fixation. In patients with severe head injuries, ream nailing did not worsen the outcomes. That's the consensus from current literature. So in pulmonary contusion or parenchymal damage, do not ream. Wait, do damage control, and then take it up. So the take-home message is intramedullary reaming is gold standard for current practice of nailing of long bone fractures. One has to advance slowly, but ream with full RPM and go in and out. Do not get stuck and do not increase the thermal necrosis by doing that. Use sharp reamers once again so that there is minimized increase in the temperatures. Withdraw frequently, as I mentioned. And one very important thing, be very wary of reaming in patients with lung parenchymal injury. Thank you very much for your attention.
Thank you very much, Dr. Ajith. It was a wonderful information on reaming principles. Any questions from the faculty members? I would like to ask you, Dr. Ajith.
Yes, sir.
Any incidents you yourself faced of fat embolism during reaming, and how did you manage that?
Yes, sir. We had, I think we have also put it up in one of the webinars. This was a patient who had on day one, there was rib fractures. CT did not show any lung contusion on day one. So because he had come early, in spite of the rib fractures, we went ahead and nailed him. But subsequently, on the third day, he started dropping saturation and became breathless. And a repeat CT showed that he had parenchymal injury, and he had to be ventilated, and he went through a very rough course, and eventually he survived after being on a ventilator for about 8 days, I think. And this was one scenario where, although the pre-op CT was normal, multiple rib fractures, I think he had about 6 rib fractures, there was minimal hemarthrosis. He went on to have problems, but otherwise in lung contusions, we do not routinely nail them now.
Thank you so much. Welcome, Dr. Gaur.
May I ask one question, Chandak sir?
Gaur sir, welcome to webinar. Most welcome. Yeah, Gadegone sir, please go ahead.
Suppose if you have a polytrauma patient already had a pulmonary insult, so how far we have to wait for the surgery after recovery? And do you do reaming while doing a second surgery? Because the patient has survived from the pulmonary insult, and then ultimately we have to take the patient for surgery.
Yes.
Whether we should ream or not.
So
after how many days we should take the patient?
No. If he is in that phase of acute inflammatory response, then we wait for that first window of 5 to 7 days. If all the parameters are normal by then, including your lactate levels, we have gone ahead and nailed them, sir, including bilateral femoral fractures. Of course, with the understanding that having done one side, if things deteriorate, then the other side we may delay it for the next time. But I think most often we have proceeded with both. I'm talking about bilateral femoral fractures, not just femur and tibia. I think Dr. Vivek may be in a better position to answer that in a major center.
Yes, sir. We do routinely nail the patients who are having an embolism or an ARDS, and we even ream them, even in bilateral, as you have said. As you have rightly said, we have to wait for the objective biochemical parameters to look at, which is paramount is the lactate levels, the ABG levels. And if both of them are less than 4 or even 2 less than, because now you are making sure that your reaming is not going to exacerbate any of the ARDS or lung contusion injuries, then you can go ahead and do the nailing part with reaming. There's not a contraindication. As was rightly said by Dr. Ajith, it's not the reaming which causes the embolisms and the ARDS, it's that amount of the lung contusion, the ALI, acute lung injuries, which are the main reasons why these go into issues of ARDS.
And
Got
sir,
it.
even in cases if we fix the femur, it will decrease the chances of the fat embolism later on. So in my hospital, it is a policy that if patient had got an insult of the chest, so then ICU intensivist counsel the patient regarding the operations. And then we fix even in the unconscious cases, we fix the femur, and so that the further insult of the lungs can be reduced by the fixation of the femur.
And mobilization and physiotherapy also can
Yeah, yes,
supervise
yeah,
faster.
yeah, yes, sir.
Thank you. Gaur sir, you were going to comment something?
See, the patient who does not have chest injury and a fractured femur, the timing is controversial. Now they say for damage control orthopedics, you have to fix it within 48 hours. Whereas if you see in my experience, when we used to nail them, and Campbell mentioned that after 5 to 7 days, as Dr. Ajith has mentioned, the incidence of ARDS or fat embolism was much, much less. Then doing it acutely, and it is a problem in comminuted fracture to nail it because of muscular problem. So waiting would not harm. That is what I feel.
Just to say something regarding this, there is no literature in the world to say that delayed fracture fixation in an isolated nailing of the femur leads to any further issues of fat embolism or so. There is no literature because it's mostly in the developing world that we see this. There, the developed world is analyzing whether to do it within 6 hours or 12 hours. We had done a study regarding the same procedures where we managed and tried to see the biochemical markers of all these patients who were having an isolated femur nailings done. We had around 50 cases of them for less than 7 days or less than 2 days and beyond 2 days. And this was published in Indian Journal. We managed to see there all the biochemical markers of endothelial growth factors, transforming growth factors, and whether the causes leads to delayed union or leads to increased chances of embolism. And in our cases of 50, where we all measured all their biochemical markers, there was no difference in their union rate, oblique, any of your chest problems. So this was one of the first studies measuring the exact in serum biochemical markers of VEGF, TGF, and fibroblastic growth factors along with interleukins in a young acute case as vis-a-vis a delayed case, as Dr. Gaur has pointed out.
Shiva sir, you were.
My question to Vivek as well as Ajith, is there any role of making a rent, small hole in the distal femur when you are doing the reaming to let out the pressure?
Yes, sir. This has been done in the past. Experimental studies were done, and not much difference really in the outcomes. Even I don't know whether the studies included bilateral femoral fractures. Our biggest worry is these patients with bilateral femoral fractures, but we haven't routinely done that. When the papers first suggested long back, we used to put a Steinman pin and just make a nick, hole at the distal end, like when you do a distal locking. But afterwards, we just gave it up. We never, I don't think current literature supports that.
Okay. Any incidents you faced where the canals were just unremovable? They're just blocked?
You mean with the tight canals or?
Tight canals or unremovable canals where the
No, sir. We actually, when we started nailing in the 90s, a lot of times we found, especially in the subtrochanteric area, some of the times we used to get stuck. And I used to say that these are localized osteopetrosis. I mean, we encountered many cases where we just could not go down the canal, but that was only localized.
Okay.
The other things is narrow canals is actually poor planning. Again, in our earlier years, it happened because we were very enthusiastic about nailing every case. But otherwise, we plan And if there is any indication that the canal is very tight, then some of the Indian companies have an 8-size nail. So we keep that handy and then proceed.
Okay. So with that, we move on to the next topic. We welcome Dr. Shivashankar for his talk on nailing in intraarticular distal femur fractures. Welcome, sir.
Thank you. You can see my slides
Yeah,
as well as visible.
Yeah.
Yes,
Fine.
yes, sir.
Thank you. So I'll be talking about intraarticular fractures of the distal femur because a extraarticular fracture definitely in the distal part of the femur, even in the lower third of the femur, a supracondylar nail or a distal femoral nail is the treatment of choice. But I am in this talk dealing with intraarticular fractures in this area. This is a young lady with an intraarticular fracture, C1 type of fracture. I have done the nailing long time back, sometime in 2010 or 11. And this is at the time of implant removal and after the implant removal. You can see that there is hardly any scar over the thigh, a small incision for the locking and on the knee for insertion of the nail. Intraarticular fracture, the fracture site can be felt through the small incision taken over the knee, and you can reduce the fracture and fix them and do a close percutaneous nailing in these cases. Another elderly man, little more complicated. Here you can see the intraarticular element is simple, but the supracondylar combination is there. Again, percutaneously with the help of clamp, we reduce the fracture, then did the supracondylar nailing. Again, this is done in 2006, and this is the function at 6 weeks time. The patient had a good knee function already, and this is the wound. And this is at the time of implant removal at 4 years. You can see that the fracture has consolidated beautifully and patient had an excellent outcome. A little more further complicated, a complete compound fracture to begin with lot of comminution in the supracondylar area. I had to get a nail with only 2 holes done, because if the third hole was there, it would have come at the fracture site. So I got a special nail done with only 2 holes. And this is the immediate post-operative picture. I advised him bone grafting at 6 weeks time, but the patient never turned back, and he only came after 2 years with this union with full function. Subsequently, his implants were also removed. This is a little more complicated. Intraarticular fracture of the proximal distal femur, as well as fracture of the proximal tibia, a floating knee injury, where I have used the supracondylar nail both for the femur as well as the tibia. This is 1 month post-operative. This is 10 weeks post-operative, and the fracture united without any problem. Coming to much more complicated cases, this is a case of fracture of the distal femur, badly comminuted with intraarticular extension. There was a OFA element, and there was a split, vertical split of the fracture of the patella also, which I really missed in pre-operatively. During the surgery, I could feel that, and I fixed that during the surgery with 2 transfer screws. This is the immediate post-operative picture. You had to play jigsaw puzzle with this fracture. You have to open medial parapatellar incision I had taken. Then I opened the fracture, put back all the fragment together, then fixed temporarily with KYs. Then after fixing the intraarticular fracture properly, then I have done the nailing by taking proper incision, proper entry. You can see the incision and the function at 4 months time. This is 3 months post-surgery, and this is a 9 months patient had an excellent flexion. And at 2.5 years, this is fracture consolidated, and I had the removed the implant. Patient had full function of the knee joint with this bad intraarticular fracture. Another compound fracture to begin with, patient was referred from a distant place, and again I used the compound fracture itself, and he took the incision covering that part, and I have again put back all the fragments together, and then I have made an entry for the nail. Basically, you have to fix all the fragments with KYs temporarily and take a make a hole for the nail. That is very, very important. And once you make a hole, the fragment should not get separated. That's also very important. Then you can put the nail, and this is at 4 months time. The patient had about 70 degrees of knee flexion, and by the time the fracture consolidated and healed, he had about 110 to 120 degrees of knee flexion. So this is after the implants have been removed in this patient. Sometimes the fragments will be so small. Again, one more compound fracture to begin with, badly comminuted distal femoral fractures. Again, I could not even pass few screws in such a bad fracture, and I had to just put few KYs and leave it there. And patient had a stiff knee at the end of the union, but during the implant removal, we did the release of the quadriceps. The adhesions of the quadriceps are released from the distal femur anteriorly, and the patient had a about 90 to 110 degrees of knee flexion after the surgery. So you have to take in comminuted intraarticular fractures, incision, either medial parapatellar or lateral parapatellar. Wherever there is more comminution, I take the incision on that side. That's my simple funda here. Majority of the cases, I take a medial parapatellar incision. One more case, again, you can see that such a bad comminuted fractures, you have to put all the fragments back in position. That is the basic crux of the treatment. So you cannot do this with a bad C2, C3 type of fractures with just a close type of nailing. You have to open, put them back and do the nailing. This another case, again, you can see the combination with the bilateral HOFA in this patient. And this patient, again, I have treated with a suprapatellar nailing, again with the fragments were too small, where I have used KYs, and this is at around 13 months when the patient had fairly good range of motion, about 100 degrees of flexion he had, and this was the fracture showing union in this patient at that time. This X-ray, this is an extraarticular fracture. This X-ray I borrowed from Dr. Gadegone, and why I am showing is, if you respect the biology, union will happen without any problem. Close nailing has been done. There is hardly any bone anteriorly as well as medially you can see in this patient. In spite of that, the fracture unites in due course of time, and the patient will have excellent outcome. So respect the biology, union will happen. Again, one more case of badly comminuted distal femoral fracture. Again, this is the intraarticular intraoperative picture showing the comminution. These are some of the clinical picture showing KY temporary fixation so that it will not come in the way of the nail, and then doing the nailing in this case. So you can see that there is hardly any bone medially. Because of the comminution, there is only bone was all pushed to the lateral side. This is the immediate postoperative period. If you see the alignment will be good. But if you see there is a gap medially, if you use a plate with such a large gap medially, there is compressive forces working, and that will lead to failure of the implant. So for that purpose, you have to either put bone graft there or you have to put a medial plate. But whereas when you are using a nail, the compressive forces will get shifted laterally. On the outer side will be the tensile force will be working. When you insert a nail, the compressive forces get shifted laterally more toward the center of the bone or along the biomechanical axis, and the tensile forces gets minimized. So that is the reason why a intramedullary implant is at least 4 times more stronger than a extramedullary implant like a plate. So this is one of the reasons why I like to use nail in all these cases. You can see with this lot of comminution and as well as gap medially. In spite of that gap, if the alignment is good, the nature will take care of that, and the fracture will unite in due course of time without any trouble. This article, I wish everybody should read. This Anderson article in 2009, they talk about the amount of callus. When you use a stiff plate, the locking plate on the lateral aspect, there will be minimal callus formation on the medial side, and there will be no callus formation underneath the plate. At about 10 weeks, 12 weeks time, there is 0 millimeter cube of callus formed medially. When you use a nail is like a dynamic implant. It is like a Elizero. There is minimal axial micromotion which is happening that helps in throwing lot of callus. And another important aspect is this callus is not only on one side, it's global all around. So you can see with a plate, minimal callus only on the medial side after a long duration of time. But whereas with a nail, you see secondary type of callus all around in the immediate postoperative period in much more earlier time than with a plate. This is the reason why we all should switch over to nail. And nailing is definitely a good option. Yeah, I have shown quite good number of cases where in a badly comminuted C2, C3 type of fracture also I have been using and getting good results. So to have some dynamization underneath the plate, this spar locking cortex principle has come into market, but somehow it has not taken up because of the costly nature of the implant. This is not very popular at this stage. So this is one of the case of a spar locking cortex where there is minimal dynamization happening underneath the plate between the screw and the bone. Nowadays, we have got multi-locking nailing. Earlier, when we used to do the nailing, there used to be bell effect in the distal femur, and we were only doing mediolateral locking. And in such cases, to avoid the bell effect, we had to put the blocking screws. But with the availability of multi-locking, multi-directional locking available, that problem has been solved to a great extent. And the use of blocking screw is very, very less in the distal femur nowadays. And again, because this is a dynamic, nailing is a dynamic fixation, huge amount of callus, secondary callus forms all around without any problem. These are some of the reasons why I prefer nailing. It's a stable construct, centrally placed implant. It's a biological fixation, minimal soft tissue damage. Biomechanically, it's much more stronger, as I said earlier. A strong distal fixation in osteoporotic bones is possible with 4 to 5 screws with multi-locking nail available. Reliable bone healing can be predicted in these cases. Nail has equal axial resistance and comparable torsional resistance against when you compare them with the plate. It obviates the need for medial plating or bone grafting, medial bone grafting. As it reaches up to the lesser trochanter, it has a long working length. And because of this long working length, again, the stress over the fracture site is minimal, and the chances of implant failure compared to a plate is much more less. This is the sort of the nail I have been using for the last 7-8 years. Since 2016, I'm using this. This is a special locking screw within the nail. There are threads within the nail in the distal locking hole, and these locking bolts can be passed, which gets locked within the nail. So the mediolateral or movement of the nail happening over the interlocking bolt has been minimized to a great extent. Here I'll be showing some of the cases. These are the cases come from collection of Dr. Amit Ajgaonkar from Mumbai, Dr. Jaimin Washi from Ahmedabad, and myself. So we share all our cases together for the benefit of showing for academic purpose. This is a distal femoral fracture where I have used a supracondylar nail. Again, this is the 3 locking bolts I've used. The patient refused to come for follow-up, and actually recently he had to come for some other purpose. He had a sore over one of the middle toe. So for that purpose he came, and he was not ready for the X-ray. Then I had to get a free X-ray done for the femur, and this you can see that the fracture has consolidated very nicely. Patient is able to walk comfortably. This video is available on the YouTube, multi-lock supracondylar nailing. In that, the same person's video I have used to show in the YouTube. So he had this bandage you can see on the left middle toe. For that purpose, he had come, and I have taken the X-ray. Another hefty lady with an oblique fracture. I did a encirclage wire in the center at the fracture site. I will not show the encirclage wiring, but you can see the clinical picture. This is after a month's time. You can see that I didn't do the proximal locking also, as the nail was snugly fitting, and it was also already jetted out from the piriformis fossa. And this is at our 9 months time. Patient had an excellent outcome with good union of the fracture. This is the patient walking. Because of the knee varus and the obesity, she is walking with a waddling gait. Otherwise, she is not having any problem with the supracondylar nailing. Another young patient with a polytrauma. Let's restrict only to the femur. As the fracture was comminuted, what I did here was I did a nailing first. I did a supracondylar nailing, and percutaneously I applied a locking plate also by the side, so that I'll get back that length, as well as I will not do unnecessary collapse and shortening of the femur. The patient was put on a knee brace frame like this. I always keep all my knee patients operated with a 90-degree position. The reason is getting flexion is not at all a problem if you keep it in 90-degree position. If you keep the leg straight and it is extended, getting back the flexion is very difficult. So it's always better to put the knee at 90-degree whenever you operate. Whatever the method you operate, you can put the patient on a 90-degree frame like this, and the getting flexion as well as extension will be very, very easy. This is the immediate postoperative picture. This is follow-up picture, and this is at around 4 months time. You can see full function of the knee, and the patient was able to walk comfortably. This is the picture I have got at 7 months time. On the right side, I have done the surgery for the femur. On the left, he had a bicondylar fracture of the tibia. There is little valgus in that area, but right side femur united beautifully well. This is another badly comminuted supracondylar fracture with the intraarticular extension. Again, in this case, we had done a supracondylar nail, multi-lock nailing, and with one proximal locking. All these cases, if you see, the nail goes up to the lesser trochanter. We use minimum of 36 centimeters of nail nowadays. Another extraarticular fracture, distal femur, again treated with the nailing, and this after 1 year with beautiful consolidation and full function of the knee joint. This is Dr. Amit Ajgaokar's case, intertrochanteric fracture, fracture shaft of the femur, and condylar fracture of the distal femur. All have been tackled with a supracondylar nail with a DHS additionally, and this patient had a the middle fragment which was rotated was derotated and kept back in position after some time. This is the sort of the nail he uses. There is no locking option, means the locking bolt doesn't get locked within the nail here. This is a different type of nail he uses, and the patient at 6 months had full function, and this is at 18 months. You can see patient having full function of the knee with full consolidation of all the fractures without any problem either to the patient or to the surgeon. Another fracture, again a distal femoral fracture. The CT scan 3D reconstruction showing intraarticular element. Unfortunately, the 3D reconstruction did not show the Hoffa fracture. After fixing the distal femur with the femoral fracture with this multi-lock nailing, this is a sort of bolt which can be compressed from both the sides. So this is not a cancellous screw, it's a bolt which can be passed through this nail. So from either side, you can compress, especially if there is an intraarticular fracture. This is very, very useful. And a proximal locking has been done. And on table, we could recognize that there is a Hoffa fracture, Hoffa element. So we have fixed that with just a cannulated cancellous screw, which is passed from the side from the femoral canal, femoral distal femur, not from the articular surface. So this is all the incision which has been taken to fix this bad comminuted fracture with a Hoffa element. This is immediate postoperative picture showing nice alignment and nice reduction of all the fragments. This is a follow-up picture. This is at 7 months when the patient had come last. The patient is walking comfortably. This is the clinical picture at 7 months when the patient was walking. Another similar fracture, again treated in a similar fashion, again went on to unite without any problem with good outcome. As you can see, this is at around 9 months time when the patient had a beautiful outcome with the knee function. A segmental fracture of the femur, again treated in similar fashion, again went on to unite with good outcome. Very distal femur fracture. As long as you are able to put 2 or 3 screws, then it is usually unite without any problem. Like Arjuna, you have to keep the nail in the distal fragment in the center, both in AP and lateral. That is the crux of the whole treatment in this case. This is at the time of fracture, consolidation at 1.5 years time. This is the full function of the knee. So to conclude, I can say that there are some cases which are very good indication. A double fracture or a segmental fracture or a hefty patient with a bilateral fracture femur is a good indication for supracondylar nailing. Then again, this is a fracture shaft femur with a condylar fracture of the distal femur treated with that. Fracture neck femur with fracture shaft femur, again, you can use 2 implants instead of using 1 implant, giving both respect to the fracture, the neck as well as the fracture shaft. You can do the supracondylar nailing as well as the DHS from the top. Floating knee injury, again with 1 set of implants from 1 incision, just from 1 infrapatellar approach, you can insert both the nails and you can get away with this one set of implants only. If there is a prosthesis proximally, if the patient has distal femoral fracture, again, you can use a distal femur nail. Or even if there is a knee prosthesis, if the knee prosthesis has a space for you to allow the nail to be passed through the notch, then again, in such cases with a peri-implant fracture, you can use this nail. So what is important is perfect reduction of the joint. So you have to open and put the all the fragments together by jigsaw puzzle. Correct the alignment. That's the reason why we prefer to use longer nail up to the lesser trochanter. And your nail should be passed only in the distal fragment, in the center of the distal fragment. Don't look at the close reduction and passing the guide wire across into the proximal fragment. Only look into the distal fragment and keep your guide wire in the center of the distal fragment, both in AP and lateral. Then only your alignment will become correct. A solid stability and disturbed healing can be given with a supracondylar nailing. Early function of the knee joint can be observed in all these cases. So friends, supracondylar nail is a very versatile implant coming back in a big way with the complications of the plate nowadays being now known to everybody. Now definitely supracondylar nail has more space for you in your armamentarium. When I see a X-ray like this, a badly comminuted femoral fracture with supracondylar fracture, the first thing which comes to my mind is to do a supracondylar nailing. Thank you very much.
Thanks a lot, Shiva sir. Wonderful display of nailing principles for difficult fractures of femur and all complex situation as well. Any questions from the faculty members?
Shivashankar sir.
Yes.
Actually, you have done a wonderful job showing a number of cases. Actually, probably you have a number of volume is much more about the intra-articular fracture nailing. My question one, the restoration of the articular surface by open reduction and plating in view and against the nailing, what is your experience and ultimate range of movement at the 6-month follow?
Whether I am biased or not, I am not sure, but my results with the intra-articular fracture of the femur is far better than even extra-articular fractures with the nailing. So I feel that probably our expectation in such bad fracture is less, and we feel that we have won the battle. That's probably the one reason. But definitely, as I shown, majority of my patients have regained about 120 degrees of knee flexion. That's not at all a problem, even with C2 and C3 type of fractures. So, and the problem with plating is unless there is not much of combination medially, only a lateral plating is good. Otherwise, with little combination also medial, we have to add bone grafting, we have to put one more plate. There are so many things, and we see a lot of complications with the plating. Unfortunately or fortunately, the number of cases people do with nail is less. That's why probably I am not seeing so many cases of complication also. That could be also one of the reasons. But people call me to do nailing in such cases. That's the reason why I got a large series of such fractures I've treated with nailing.
Dr. Shivashankar, I have 2 questions for you. The first one, do you still apply the plate in some cases? And if you are doing plating, then how you decide in which cases you have to put the plate and you have to put the nail?
I'm more comfortable in putting a nail rather than putting a plate, one. And between 2006 to 2012, I was using plate, and I've done quite a good number of plate also. But again, after reading the Anderson article, though it published in 2009, I read that article in 2012. And once I read that article, and I have shifted back again to nailing, and I have not repented.
So you are presently using the nail in all the conditions.
Yes, as if it is nailable, yes, definitely I'll nail it.
Yeah. Welcome, Tanna sir, for the webinar. Welcome, sir.
Hello.
Yeah.
Good morning, sir.
Good morning, sir.
Good morning, everybody.
Good morning.
Morning, sir.
Yeah. So,
Chandak sir.
yeah, please. Go ahead.
Sir want to present, I think.
Yeah. After this, we'll be taking Dr. Tanna sir's presentation. So
You have my video presentation, eh?
Yes, sir. I'll just share this
So,
screen.
It was sent yesterday. I'm not PPT, but a video, which
Yes.
I have taken on the Zoom now.
Yeah, I'll just share and see whether it works.
It will work. Only voice, anyway, voice you will give now.
I'm on the net. I'm on the net here.
Chaddha sir, probably you have to talk.
Yeah, it is just starting.
Yes.
The video is starting.
I think this.
No, it's just starting. Hold on.
Okay.
We couldn't delete this earlier part, which we were just trying to set it up. Naveen couldn't do that.
Okay. We'll just wait for that. By that time, any question? Dr. Shiva just finished the talk on distal femur nailing procedures.
Yes, Dr. Chandak, I want to make a comment and a question.
Yeah, please go ahead.
Distal femoral fracture has been very difficult to treat.
We are barely able to hear you, Gaur sir. Possibly your.
There are some issues with the speaker.
Bandwidth appears to be a bit low.
Or sir, you can switch off your video. You are not audible.
Having very good results in the past, and the angle play for that. There is some problem with the audio, I think, in between. So, can you hear me now?
Yes,
Yeah,
yes.
yes, better. Yes.
So, when LCP came, Shivashankar, everybody moved to LCP fixing all these fractures.
Yes.
And the standard nail came, and then it went off. Then multi-lock nail came, and again it is coming back.
Yeah.
So in extra-articular fracture or C1 type of fracture,
I think again I'm not able to hear.
You are propagating does not hold well. You have to put the screws away and hold it. So, do you think the multi-lock nail will be more commonly used in the future?
Yes, definitely. I have heard your question partly because I couldn't hear totally. But even then, I can say that definitely the suprapatellar nail will come back with the vengeance again. And now we all know every procedure will be used very frequently whenever it comes new. And once we know the complication, now we know that where to use it, how to use it. And over a time, we all know the tips and tricks of the trade, and that will have its own place in the market. That's what I feel. But definitely nailing is a far better option. Biomechanically, it's better, stronger. It's not that I don't want to say that plating is bad. No, if you do plating, it requires medial plating also, bone grafting also. So additional procedures which are required usually with a plating can be avoided if you are doing a proper nailing. Doing nailing proper is also very important.
Thank you.
Chandak sir,
Yes, go ahead.
share the screen.
Yeah, I'm just sharing the screen.
So in conclusion, it is better to have expertise on the procedure, not on the implant as such.
Correct. I have shown 3 types of nails. We 3 people use different type of nail. I use one company, then Amit Ajgaonkar uses different, and Dr. Jaimin Washi uses 3rd variety. So there are varieties of nails available. So technique is important. Yes.
Hey, you're able to see the screen now?
Yeah. Yes.
Slide.
Yeah.
ના હજુ આના પર ક્લિક નથી કર્યું બરાબર આ જબો આગળ તમારે આગળ પાછળ કરવા માટે આ છે આ બધું કેમ પેલું
એ તમને દેખાય છે, એનાથી ચિંતા ના કરતા તમે.
ઓકે
એ તમને દેખાય. તમારે આ વિડીયો બીજી જગ્યાએ મૂકવો છે? વિડીયો ક્યાંય મૂકવો છે બીજી જગ્યાએ?
ના ના બરોબર છે that is right.
એક મિનિટ, ફૂલ સ્ક્રીન થયેલું છે. ફૂલ જ થયેલું છે.
Can you make it full screen? I can't see. Video એકદમ
હા,
extreme મૂકી દે ને.
હા, એટલે તમને સ્લાઇડમાં નડે.
હા.
રાઇટિંગ વાંચવામાં.
Exactly.
તો અહીંયા નીચે.
Yeah, there will be no writing.
રાઈટ. એ તમને નડે.
So the pre-operative session is going on.
આગળ ને પાછળ તમને પેલું રિમોટ જ આપી દો ને સર.
Naveen, can you go ahead now a little forward? Junctional fractures.
ચંદોક.
Yeah, ready, sir.
Ready. I'm now first talking on upper 1/4 junction to lower 3/4 junction. These junctional fractures are comminuted unstable subtrochanteric fractures at the junction of the IT and the shaft are very unstable only in nail. I strongly feel such comminuted fractures should be plated along with the nail. So this is a combination which is far more safer. Occasionally it may be an overkill, but still this is the treatment of choice. Only nailing is unstable in such comminuted fractures. Now you can see this fracture, which has been nailed. 5 months have passed by, non-union. So that's the reason why you had to put in a supplementary plate. And that is the one which ultimately it held up after 4 years. So if such a fracture on day one, when the proximal hold of the implant is very poor, lower hold is decent, this fracture is the one which I feel I'll augment it on day one. Comminuted, and I'm not talking about the transverse fracture. Comminuted fracture, in this situation, junctional fractures are unstable only in nail. More non-union chances, overkill. It may heal up. If you think that you don't need it, you may not do it. But the safety situation is you put in a plate and there is a much better chance of healing for this fracture. As you can see, this fracture, on day one, I had put in a plate, fracture healed up, the patient walking about, moving about, is a better chance for the fracture to heal up. Now you can see these fractures. Can this ever heal up? This comminuted fracture in a nail. You can say you can put in a better nail with the screw in the neck, 1-2 screws here and there. But I feel such a comminuted fracture is a very poor chance of healing. And here, you can see this. This is the one, if you had put in the nail and a plate, this has a much better chance of healing. Or here, you can see proximally, the hold of the nail is very poor. Distally also, it is not very good. So such fractures have a comparatively lesser chance of healing. In these osteoporotic bones, probably the adjuvant plate may be a better option. I do not want to say that it will not heal up without the adjuvant plate, but the chances of healing and chances of non-union are reduced dramatically if this adjuvant plate is put in. As you can see, this long oblique fracture, this is unstable in nail. Everything is bent in 2 screws, and this is unstable in nail. This is an excellent hold over here, but this is unstable in nail. So it went on to non-union, pain. So ultimately it needed plate fixation. So this is the one on day one, I will do an adjuvant plate in such sort of a comminuted or a long oblique unstable fracture. Now this is the fracture. This is the orthopedic surgeon's wife. Treated upon, this piece came out. So the proximal hold has become poor. And this ultimately ended up like this. So this fracture, if it has happened this way on the table, this piece is broken off. Probably it's the one you put in a PFN, put in a hook plate, and then you have a good fixation there. This is a superb stability. And the patient walks about on day one, and everything is held up extremely well. Now I come to upper 2/3 and lower 1/3. This is the one where the hold is very good proximally, but distally the hold is not very good. This needed a supplementary plate for it to heal up. You can see this lower round down, there is no hold, so it is swaying. Once it is swaying like this, you have a lysis which has occurred of the fracture at the bone. While this fracture which has been done, you can see it is not holding properly. And that is the run. You can see here, the nail has no hold on the distal end. This is the CT scan. Proximally, it is a good hold. And that's the reason this is the one which goes into non-union with antegrade nail. Probably been claimed as antegrade nail with 4 screws or a nail from the lower down with 4 screws distally has a much better chance of healing. Here you can see there is 3 screws have been done. Still, this went into non-union, so it needed another operation there. I feel lower femur nail, distal femur nail, is a much better option. As you can see here, I have done the distal femur nail, and then it is moving about, and still there is no instability there. So I went on, and ultimately it healed up. The hold over here, subchondral hold of the nail, is the one which is most contributory for the stability of the distal fragment. It is enhanced by 2, 3, 4 screws. Nowadays, you can put in 4 screws into the distal fragment if there is a place. So that's the reason why a DFN nail in a subchondral, which is the biggest and the best fixation for this. Now, this is the type of a nail which is now available, distal femur nail with 3, 4, 5 screws and a plate. Though it is not available in India, this is the one which will give you probably a much better fixation. But still, the best part of it is subchondral nail is. It is the one which is a subchondral nail where the nail is holding very well. So that's the one which gives you the best chance of healing. This subchondral distal femur nail will work in junctional fractures, but it's not sure. Why not an adjuvant plate when in doubt? Overkill it may be, but that adjuvant plate will probably assure you that patient doesn't go through the second surgery. Now this was the fracture, comminuted long oblique fracture. I treated on the day 1 with the long antegrade nail and a plate. And everything healed up. Patient walks about, moves about on day 1. Be on the safer side instead of if it doesn't heal, we'll do it. I feel such junctional fractures are better off with this double plating. Now this is the fracture. The arthroplasty surgeon operated this. So he went back to the arthroplasty surgeon. He did the nail. Now you can see the nail. 2 screws he has put in, but the nail hold is very poor. This ended up into non-union. Ultimately, I treated it with a long plate and a bone graft and everything is healed up. But this Maharani, if it was nailed and plate, it would have healed up very well and it would not have any problem. That's the reason day 1, overkill is not a sin. Here it is again a lower 1/3 fracture with the comminution here. Again, the non-union, and that's the reason why it had to be done there. Here is the fracture, though it's not that lower 1/3, but still it is a poorer hold on the distal fragment, so it needed an adjuvant plate for the fracture to heal up. So this sort of a non-union that patient goes through 6 months and then gets operated upon and another 4, 6 months. So it's such a long journey for an orthopedic patient. I feel it's not a sin to do an overkill on day 1 into this sort of a junctional fractures. Now I come to lower tibia. Oblique fracture lower tibia. Nailing is ideal with 3 screws lower down, as you can see. Probably this nail could have been subchondral, but it's not very easy because you cannot really ream it with the normal ways. This nail broke down, the plate broke down, the long short oblique fracture. Unstable construct. This is another fracture. After nailing, it was unstable, as you can see. This was unstable after even plating the fibula. Still, it was unstable. as you can see very well. And that's the reason why ultimately on the table, I decided this instability is not acceptable to me. And I put in a plate on the side. And this is the one after five months, the fibula plate is there. And this is the one after 5 months, it is held up. Patient is comfortable walking about, moving about on day 1. Or this is another lower 1/3 tibia. Fibula has been fixed up. The tibia was fixed up very well and it was nailed. But in order to be this such an oblique fracture, I didn't want to take any chance. So I put in the plate, and this plate which is put in, and just you can see it in 2 months' time, the healing process is started and patient is very comfortable. I'll not say this fracture will not heal up without a plate. I agree. But this small plate, which is MIPPO, it helps for the fracture healing to the greatest extent. Upper 1/3 tibia, nowadays they are treated with a suprapatellar nail, which probably is a better option. But even if the nailing and the reduction and everything is good, the chances of non-union are higher. This was the non-union which had to be treated with this double plating and a grafting. Or you can see this fracture. Good nailing, good reduction, but still fracture went into non-union. Overkill on day 1, if you had done the plating along with it, it would have held up very well. I'm talking about these junctional fractures only. Now here you can see this fracture. 4 screws proximally, a long oblique fracture. 5 months pain. And this is the other fracture, lower 1/3 oblique fracture. 5 screws lower down. And this is the one which is a polar screw, which you can see. Till 4 months pain. On day 1, adjuvant plate would have probably solved the problem. Or the same thing is over here. Adjuvant plate would have solved the problem. Patient would have been all right. Radiologically, it may take a little longer time to heal up, but it will heal up. Conclusion, overkill on day 1. Why not? What is the harm? At least in a doubtful fixation with the doubtful instability, we must do it. Thank you very much.
Thank you very much, sir, for that wonderful concept of overkill for this junctional fracture. Any questions from the faculty members?
Chandak sir, may I ask question 1?
Yes, sir, please.
Bolo.
Sirji, do you do adjuvant plate first, this nail adjuvant plate and then locking, or you do a nailing, complete the procedure and do a MIPPO adjuvant plating?
I first complete the nailing procedure completely, see for any instability if it is there, and then put an adjuvant plate.
But after a nailing, whatever the reduction you do it, some translation here and there, it remains because of a close nailing. In a situation, before you locking, suppose if you do an adjuvant plate first and then lock, it will give a better stability as well as the better correction of the reduction.
I agree. But do you feel that minor displacement in a nailing is going to be an issue?
No, it does not matter very much.
So radiologically, you will improve the situation probably. I agree.
But Dr. Gadegone, then putting the screws of the plate before the nail will cause problem putting the nail. So it is better to put
He's
the
putting
nail.
that, put a nail
First.
And then put in a plate to correct the minor displacement and then lock it distally.
Sir, can I just ask one question?
Right.
Yeah, go
Bolo,
ahead.
Ajith. It's about that one particular example where you showed 4 or 5 screws in the distal segment.
Yes.
Generally, the principle is some sort of relative stability has to be there with an intramedullary device. So now we are having a conflict of principles here. You are having relative stability and then the plate is eliminating that relative stability concept.
You want to make the fracture heal, or you want to abide by that small principles which has been given at one time.
So,
Because I
yeah,
think
the
if
question-
the fracture heals up and the patient is functionally moving about and walking about on day 2, day 3, this is all what we are functioning about, basically. What you
No.
agree, what you say, I agree. But in any situation, nail and a plate has almost succeeded, I would say almost 100% of the time, if you have been able to do it. Would you agree to that?
No, I agree. No, my question was, sir, how would the operating surgeon decide on table? Because many of us, when we are nailing, we put the patient on a fracture table. So it is difficult to assess those minor movements. That's for the decision making, for the benefit of junior surgeons, how to decide.
See, I have talked about the junctional fractures only.
Yes, sir.
And a junctional comminuted fracture proximally, which we do it in a fracture table, I agree. You cannot judge it. But the distal femur, we don't do it on a fracture table. Lower tibias and upper tibias, we don't do it on a fracture table. So there it is comparatively much easier to assess.
Okay.
In a proximal femur, junctional upper fourth, 1/4 and lower 3/4, I feel they are the really dicey fractures once they are comminuted like this. And without even proving that they are stable or not stable, I'll go ahead and put in a plate there. This is what I have been speaking about. While in the lower 1/3, I will see for the stability. If there is a stable fracture, then I may not do it. But as I said, overkill to me is not an issue.
Thank you, sir.
Thank you very much, sir. In spite of busy schedules at Indore, you joined and delivered this talk. Thank you so much. Moving on, we move to the next.
Thank you. Thank you, everybody.
Thank you so much.
Thank you, sir.
Bye. Bye. Thank you,
Bye.
Naveen. Thank you, Naveen, for doing everything for me.
Thank you, sir.
Thank you. Thank you.
With this, we move on to the lecture from Dr. Vivek Trikha. So, nailing in associated intraarticular fractures. Please share your screen, sir. Thank you so much. We can see the presentation. Fine. Okay.
Thank you, sir. Thank you, Dr. Gadegone, sir, and welcome to this IOA subcommittee of nailing, which has been doing some active, very good teaching purposes work for all over India as well as abroad.
This is
My
your
talk-
inspiration. This is your inspiration.
No, sir, it's all your effort and your guidance which is doing this. And Dr. Shivashankar, as well as your other colleagues of Santosh and Dr.R.M.Chandak, sir. Intramedullary nailing in combined fractures, and I'll be dealing with articular. Some of that will be overlapped with the first talk of Dr. Shivashankar, sir, and the next talk, which is subsequently to me, like by Dr. Gadegone. But remember that what we are discussing here are the combined articular and shaft fractures, which is highly unusual and a high energy mechanism injuries. Remember that they are usually associated with other associated injuries like polytrauma, other organ injuries, or other long bone fractures in at least 60 to 70% of cases. Limited treatment guidelines are available out here, and we need to see, because over the years, people have gained their experiences and ensured that let's say that, or they have provided their own guidelines for this. I looked around in the literature, and only one of the papers for the proximal femur was there, or the femur shaft with intraarticular fractures, a retrospective case of nearly 25 cases, where they had 10 cases with shaft, neck, as well as distal femur, where they managed with intramedullary screws and nails and screws alone. If you look at the tibia also, tibia is also having very less literature. Only one of the literatures which could be found, where out of 1,500 cases, only 50 cases of non-contiguous. That is, we are not talking of fractures which are intraarticular extending into the shaft, but we are talking of fractures which are separate associated diaphyseal as well as intraarticular fractures. And they use nail plate constructs in them. So if we start looking at these fractures and how do we diagnose these fractures, the first thing to look at these fractures will be to have a CT scan, because CT scan alone can tell us whether there is an intraarticular as well as a diaphyseal area which are separate from each other. You can see that intraarticular fracture is there and a diaphyseal in both these CTs of the femur as well as tibia. The principles is, as we discussed, an articular fixation is anatomical. with absolute stability, and diaphyseal fixation is with relative stability. Maintain mechanical axis and alignment is the key thing for us. And it has to be done with the best possible fixation, which we can have for both the fracture patterns. Now let's see some femur cases examples. This is a 40-year-old male operated in 2017, where you could see he has a neck femur, shaft femur, and a fracture which is separate going into the intraarticular distal femur fractures, lateral condyle. You can see the CT scans tells us that there is a segment which is a separate diaphyseal and an intraarticular fracture away from this, and a neck femur fracture as well. So since it was having a neck femur fracture, just a minute, there's a lot of noise out here. So sorry for that. If you see what we did out here was that we went in for the neck femur fracture, we had to go with an anterior grade nail. So we kept deliberately our fracture as small, as length of the nail as slightly short, and fixed the distal fracture separately with first with K-wires and then subsequently with lag screws. And this is how that neck femur, shaft femur, and the distal femur were fixed with the best possible fixations for all the three fracture patterns. This is a subsequent where you can see that the fracture has started uniting. Now let's look at another fracture pattern where the shaft is also there and there is a HOFA element for that. So Dr. Shivashankar showed wonderful cases which are much more complex than this, but I'll just show some simple cases where you have an sagittal fracture, coronal fracture plane along with a diaphyseal shaft fracture. So here again, since it is a coronal, you can do it separately. So the coronal fracture was fixed with K-wires first, and a regular entry point for the distal femur was made, which ensuring that the reduction is proper, and the K-wires were holding the HOFA's element for us, which was subsequently replaced with the screws. This is his 6 weeks.
Shall I interrupt, Vivek?
Yeah.
The nail has been passed at 180-degree reverse. Actually, the distal femur curvature, the nail has.
I understand that.
This is a very
That's
common
a very
mistake
common mistake which is done, and because of the many times the pliability of the supracondylar region usually will have some deformities which will be exaggerated, but if it is pliable, it will not have much of the deformities. And this is done and fixation at 6 months, with subsequent 4 months, which was there. And you can see that the fracture has united, which was separate for the diaphysis as well as separate for the HOFAs. Now, again, a fracture having a neck femur, shaft femur, and a separate lateral condyle. Since this lateral condyle fracture was quite long and was going higher, again, if you can see that this fracture was going slightly higher for us with a PCL avulsion, which was also there. We again went in with a neck femur antegrade nailing for that. But here, along with the screws which we had done previously, we took a plate, a simple plate, along with the lag screw, which is there. The neck appears to be slightly in rotation, which is there. And then subsequently, the PCL was fixed from the posterior aspect of that. And if you see 3 months later, the fractures have united. So it is just giving the optimal and the best amount of stability for individual fractures, which can be combined with the nailing, as well as the intra-articular fractures can be combined for the plating or by screws, depending upon the fracture pattern and the length of the fracture. So if we are talking of the bifocal femoral injuries, remember that many times, which are non-contiguous fractures, which we are talking of, unlike many of the fractures which Dr. Shivashankar showed, which were contiguous fractures, reduction of articular fragment may not be dependent on diaphyseal components. We can choose the fixation modalities as per the individual fracture pattern, because that gives us a leeway because it is a non-contiguous fracture pattern. And both, I have shown you examples of antegrade fracture nailing as well as retrograde nailing, in addition to screws vis-a-vis plates, depending upon the intra-articular element which is there. So you get the absolute stability for the articular fracture, and the relative stability for the diaphyseal fractures with two separate implants, which are giving you the best possible fixation methodology. Coming to the tibia. Again, tibia nowadays, previously, that was not many of the articular with fractures of the diaphysis were there, but over the present last 4 or 5 years, I would say that their incidence has increased, and we are having combined and combination injuries in a much more intensity or incidence, if I can say that. So here you have a segmental tibia along with an articular depression. Now, if we want to fix this segmental tibia, we need a diaphyseal or a nail, which is the ideal treatment. But how to take care of the intraarticular fracture element, which is a non-contiguous fracture again. So as we said, plates or screws for the intraarticular fragment and nailing for the diaphyseal fractures. Let's see this imaging and see how we have done this in a stepwise manner. We looked at the fracture pattern, forgot or totally kept aside the diaphyseal segmental fracture, isolatedly look for the intraarticular fracture element, lift that fracture up in a standard way like you do for an articular fracture. And once you have taken care with the bone substitute, or whichever way you want to fix them or lift up the fragments, K-wires were put and then subsequently screws were put. If you see in the lateral view, all the screws are in the center or in the posterior aspect of the thing, because the CT scan had told us where that fracture was exactly lying. And after that, you can easily put, if you see the anterior 50% of your axial section, we have a good entry point for our nail, which will be working wonders for our diaphyseal segmental fracture. This you could do with the suprapatellar nail, because that gives us a great advantage nowadays. Or even if you don't want to do it with suprapatellar nail, even an infrapatellar will do, provided how you manage it in a segmental fracture, the way we have been doing over so many years. And then subsequently, the reductions were taken for the diaphyseal fracture fragments, and the nailing was done in a standard fashion. So you have done two different incisions, given individualized treatment and adequate respect to individual fractures, and given the best optimal stability which can be given for the individual fractures. This is the post-op X-rays, follow-up, and you can see that the range of motion is there, because it was done in a totally minimally invasive way, and in a possible, the normal standard way by which we do it, the results are quite good. Now let's look. This was the first case where I had done this. It was around 5 to 7 years back. If you see, he had a floating knee with a fracture of the femur shaft, tibial shaft, and this intraarticular fracture. So we did and went about doing our nailing for the femur, twist nail. But when we saw and when we had the skin condition for the tibia, that was quite swollen, and we didn't know what to do exactly at that time. We were thinking how to go about doing this. So we initially put in a fixator to stabilize that, and subsequently found that the skin condition deteriorated for much more. And we didn't know how to go about doing, and our plating options were taken out because of this. So we had to wait for some time. And once we waited with the skin of the diaphyseal part, then we went about planning it, again a non-contiguous fracture pattern, where with the best possible fixations will be plate and nail. And we went about doing it with the nail entry site as a suprapatellar sort of an entry, or a slightly, we went about opening the paramedial site. And then we went about fixing it. And as you can see, we put in a plate along with the nail for such case, because the soft tissues for the plating of the diaphysis was not good for us. This was at 2 months. And finally at 6 months, you can see that the femur, tibia, everything had united in a proper way, giving the best possible outcome for the patient. Another case, slightly contiguous, if I can say, because the fracture is going, but it is still a small intraarticular fracture. You can see in the CT scan, get a CT scan to understand and visualize where that fracture of the intraarticular fragment is, so that you need to lift it up and whether it is going to interfere with the entry point of your nail or not. Since similar things which I have shown you before can be done for such a fracture, lifting up the fracture pattern, lifting up the fracture of the articular depression. Here we thought that the plate, because it was a split depression along with it and it was slightly comminuted for us, we put in a plate first with few screws holding the fracture and putting in our guide wire and the nail for the suprapatellar. As we had seen in the CT scan, that the fracture was posterior, the intraarticular fragment. A nail or a suprapatellar nail could easily be put for such a fracture. And the plate, as you see in the lateral, is posterior to the entry point. Screw fixations from the proximal articular area have already been done. Smaller screws were initially put, or screws which are going posterior were put so that the nail is not interfering with the plate or the screw fixation. And then subsequently, routinely, the diaphyseal fractures have been fixed in a nail plate construct. You can see the way minimally invasively it has been done. Small stabs for the suprapatellar nailing part and the tibia where the plate has been put. This is the post-op X-rays and 6 weeks follow-up. And you can see with the same fracture pattern that the patient is having good range of motion. So what are the tips and how do we plan it out? First of all, understand the CT scan, because that is going to tell you where that articular depression is and whether you can hold it with K-wires or you need and can be putting in multiple screws for the same. The articular reduction normally is done first. You hold the articular reduction with K-wires vis-a-vis a plate or a screws. And keeping your entry point for the nail as empty or virgin. Remember that the nail entry is in the first 10% of your axial scan. Rest of the fracture fragments can be fixed with screw. If you have a cross-sectional area of the axial scan of your proximal tibia, 10% of it is going to be the nail entry in the proximal superior part. Once you do this, the nail insertion will not be affecting the articular reduction. And subsequently, understanding the CT, you can fix the plate first with small screws if you require in the distal part. And once your nail has gone, the plate can be subsequently changed with long screws as well. And finally, there are some cases which are contiguous, a polytrauma case where you can see that it is an intraarticular fracture, very high proximal, along with which is going into the diaphyseal with a bad wound with just 5 to 7 centimeters of proximal end, can also be fixed with intraarticular screw fixations, and the K-wires have been done. Multiple K-wires have been put here. And once you have put in the K-wires, you have reduced the articular fracture, then you reduce your proximal shaft fracture, and a suprapatellar nailing can be done, which gives you the optimal fixation for all the fracture patterns. This is how we had fixed it. He had a bad open wound of the calcaneum. That's why we had kept the nail short, because we were not sure whether he might go into an amputation later or not. You can see that the wounds on the soft tissues on the proximal skin was pretty bad. And hence, after 6 months, you can see that he's having still a problem of the heel, but the fracture fixation has worked and the fixation has united. This is his femur as well as the pelvis. So finally, in the take home, I would say that indications for nailing have increased in the current few years. And now we can also have intra-articular fractures which can be incorporated, as was shown by Dr. Shivashankar and will be shown by Dr. Gadegone sir also now. Intra-articular with diaphyseal can also be taken care in these fractures. CT evaluation is a must. Understanding the fixation and the fractures. Articular reduction, remember, along with the alignment is the one which you need to take care of both. So make it an individualized treatment so that that is different and the articular congruity is different and axis alignment is different. Both nailings in femur are possible, antegrade and retrograde along with fixations. Suprapatellar nailing is advantageous in tibia. When you are doing these fractures, you can also do it for distal fractures where intra-articular fractures are there with shafts. And the nail blade construct or intramedullary nail with screw augmentation are viable options which can be done for both femur and tibia when we are doing these extreme nailings. Thank you for your patient hearing.
Thank you very much, Trikha sir. That was wonderful. Any questions to Dr. Trikha sir?
Dr. Trikha, if we know there is a space for the nail insertion in upper and tibia with intra-articular fractures, and we have a space to put the screws in upper and tibia through the plate, then why we don't go first the nail and then plate?
So it is just depending upon how your fracture is. When I'm doing, if it is just your fracture fragments of your intra-articular fracture, maybe extending into the place where your nail has to go, then I will provisionally fix it, because the positioning of your nailing and the reaming can slightly change my articular congruity. Hence, we provisionally fix it with K-wires. If my fractures can be very properly fixed in the posterior part, we have put in all the plate screws out right there and there. But if it is a minor one, we just hold it so that once our major, if I can say, displacements which can be done in a nailing have been tackled, and then subsequently we might to make any minor adjustments. We can do that subsequently also. So we provisionally fix them and then subsequently change them to screws. But yes, if the fragments are totally separate, we can do that. As I said, the sagittal ones are the ones where we normally do not fix them initially purely. The coronal fractures, which are Hoffa's element, or the posteromedial fractures, which are totally separate and have no having any bearing on the nailing entries or the changes, you can do whichever way and whenever you want them, be it previous to nail or post nail.
Yeah, I will add to that, Santosh. See, in when both the elements are there, when you're doing the nailing, the chances that this intraarticular fragment gets separated and it may not be looking like what you have seen in the CT is very, very high. So it's better to do the fixation of the intraarticular fracture first, then the nailing. And second thing is, the nail also comes in the way of taking a proper CM picture. So since the CM gets focused to the metal, the quality of the fracture seen without a nail is entirely different with the presence of a nail. So that is another reason why you can better visualize the fracture without a metal inside. So I would rather fix, like Dr. Trikha, intra-articular element first, then I'll go ahead with the nailing.
Thank you very much, sir.
Thank you, sir.
After this, we have Dr. Gadegone's lecture, his favorite talk on suprapatellar nailing. So let us learn the nuances of suprapatellar nailing from Dr. Gadegone. Go ahead, sir.
Yes.
Yes, we can see your screen.
So it is nothing but the stretching of the Vivek Trikha's lecture, and we can name it as stretching the limits of suprapatellar nailing, because now a suprapatellar nailing is a well accepted method in a complex tibial fractures. Now literature is also supporting, and there is no issue about this thing. So I will go that the characteristic of extreme tibial fracture is a junctional zone, paucity of the soft tissue, and presented with the soft tissue injury, often intra-articular fractures. Complications and prognosis directly related to the degree of soft tissue injury, hence bypass the precarious zone by nail, and instead of doing a plating, open reduction and fixation, always it is better to do by nail. So there are issues, nailing in a metaphyseal fractures, deforming forces, entry point and placement of the nail. Differences between proximal and distal tibia fracture is a quadriceps is the deforming forces, whereas the fibula is the deforming force. And therefore, we have to take in all account when we do a suprapatellar nailing. And there is also a difference in the proximal and distal tibial fracture. Center position of nail is important in a distal tibial fracture, whereas entry point is crucial in the proximal fracture. So having this learned basic things, how the suprapatellar nailing can be executed. So nailing in a distal extreme tibial fractures to overcome deformity of proximal and distal tibia fractures. What is the solution? And solution is the suprapatellar nailing in a semi-extended position with adjoint clamps, polar screws to reduce and stabilize the fractures. So current indications of nailing, certain intra-articular and extra-articular tibial fractures within 50 mm in proximal and 30 mm of the distal plafond. So such a extreme tibial fractures can also be managed with the help of the suprapatellar technique. Now this is a famous semi-extended position, multi-lock nail to be used and bolstered under the knee to maintain 15 to 20 degree of flexions. So this is one of the example, a compound fracture, extreme proximal tibial fracture, clamp assisted reduction. You can see here, this is a very oblique fracture going into the tibial condyle. Probably you may need such a patient a CT scan. Now clamp assisted close reduction, suprapatellar approach, and you can see how beautifully there is a restoration and apex neutralization by a polar screw. 1 year follow-up, a full function, and you can see that the patient is able to do all activities. Here now this is a 45-year polytrauma patient, compound 3A fracture of the femur, segmental tibia fracture, clavicle fracture, lower end radius fracture. I will mostly concentrate on extremity fracture here, and you can see damage control, debridement of the wound, calcaneal pin and immobilization in Thomas's splint for few days. And then after 7 days, the patient was taken for surgery, a suprapatellar approach, close tibial fixation on a simple table, final close fixation of a segmental fracture, minimal invasive surgery. And after having done a tibial fracture stabilization, multi-lock supracondylar nailing for femur, transtendinous approach, multi-lock supracondylar nailing, mini invasive surgery. So such a floating injury, a complex floating injury can be managed with a suprapatellar nail and a supracondylar nail through a transtendinous approach and suprapatellar approach. This is the example. You can see a fixation of segmental fracture, supracondylar nailing, femur and tibia, close technique, post-operative, 2 months follow-up and 4 months follow-up. Fracture has completely united of the tibia. Sometime it has taken for the femur and required a bone grafting procedure. Another example, a 60-year male. This is the segmental fracture with a soft tissue issue. Calcaneal pin was given for some time, traction and fracture alignment, clamp reduction of the proximal fragment, and insertion of posterior polar wire or pin, suprapatellar orthotomy, sleeve passage, appropriate entry and guide wire passage, concentration first on the proximal fragment and then on a distal fragment while passing the guide wire. Reaming, because to take a very special precaution while doing a reaming in a segmental fracture as given by the tips given by the Ajith. Passage of the nail, final locking, and you can see this is the post-op X-ray, mini invasive surgery by suprapatellar approach, alignment of the proximal as well as the distal fragment, and you can see after 6 month follow-up, full function and a complete range of movement. Another example presented after 10 days from other hospital, blisters, they are all yet to heal. Patient was restless for surgery, difficult to do a plating, a segmental fracture, what to do, and suprapatellar approach, clamp assisted reduction, bypass surgery, and you can see stages passing a guide wire, then nail, multiple locking proximal and distal, final placement of the nail. There is some translation of the comminuted pieces, but with the proper fixing of both proximal and distal fragment, everything held along nail, 9 month follow-up, patient is able to do all his activities. Another example, you can see this is a very dangerous injury, soft tissue issues, compound fracture at the ankle also, and the gluing of the skin, extensive soft tissue, and the patient was a controlled hypertensive but a chronic tobacco chewer. And you can see here, I have done a clamp-assisted bypass surgery, guide wire introduction, clamp-assisted reduction, and you can see there is not only a segmental fracture, for one of the distal segment was a comminuted also, and there was a very large butterfly fragment. It is a very difficult to pass a nail through the butterfly fragment. It requires a tricks and stabilization of that fragment, and your guide wire must go through the canal of that butterfly fragment. It is such a large fragment. So reaming, and you can see here, you have to stabilize the middle fragment. Otherwise, there is a problem always. Spinning of the middle segment is possible. Therefore, we have to take this precaution. Distal and proximal locking, mini invasive surgery, bypass surgery, and you can see very small incisions. All soft tissues are bypassed. They are there as it is, and you can see after 3 months of follow-up, everything, wound has healed, union is progressing, good range of motion, and patient is able to walk with support, and probably subsequently the fracture will unite. Another fracture with intraarticular extension, and you can see such a complex comminuted fracture extend into the joint, clamp-assisted reduction and plate augmentation, mini invasive surgery, and you can see here within 3 months of follow-up, fracture is uniting, patient is able to do all his activity because of his stable fixation. Another example, the 44-year-old male compound comminuted fracture extended to the joint was treated in other hospital with a debridement of wound and expect such a complex fracture extending into the intraarticular area, multiple pieces, and femur and tibia. You can see it's a swollen, pouring pus. After 2 months, huge comminuted fracture, doubtful viability of all fragments, no improvement in wound condition, and there was a showcase, protruding wound and pin tract infection. So parameters of infection, there were C-reactive proteins, ESR, they were borderline except less than 8 gram of hemoglobin. Removal of expressed, debridement of indolent wound, skin cover and cast till holes healed, and the anti-Klebsiella, the antibiotics were given. And then ultimately I converted into a lock-in plate X-fix was applied, thinking that bypassing the comminuted zone, and you can also solve the problem of a soft tissue, tethered soft tissue to the bone. And ultimately the patient was very comfortable with this and subsequent follow-up, but no progress in the healing, maybe because of the devitalized tissues. But the patient was very happy and no consolidation over the period of 4 months. And he was walking with crutches and no pain, nothing. But I was worried, as well as the patient, there was no consolidation of the fracture. So ultimately, hence removal of the fixator, functional bearers for 1 month, distracting to regain some length on the table, and ultimately a close nailing by creating a path to the sleeve of suprapatellar nail by 8 mm rigid pointed reamer first, and then by flexible reamer. Close procedure, sufficient stages of suprapatellar nailing, and you can see this is the post-operative limb. There is no scar. Everything is bypassed through this tunnel, and the suprapatellar nailing was done. It was a reaming also done, but that reaming product will help in the union of the fractures. Bone marrow instillation at the fracture site was done. Subsequently on the table, and you can see here a close locking post-operative X-ray, complete wound healing, and subsequent follow-up. 1 centimeter there is a shortening, and this is the yesterday's follow-up. 6-month follow-up. Fracture is uniting. He has resumed the duties. Probably today it looks a very difficult, very different picture, but after remodeling and consolidation after 1 year, you will find that the whole tibia is formed. Another example, extreme fracture, proximal and distal tibial fracture, long segment, very less than 5 centimeters of the proximal fragment, treated by suprapatellar approach with polar screw. Then ultimately there was a distraction, dynamization was done, union and full function. Another example, impending butterfly fragment is a difficult to treat by nailing because that that butterfly fragment, it becomes a complete while doing a nailing by intrapatellar approach. Stabilization of the butterfly fragment becomes a very difficult. So clamp assisted reduction, passing the guide wire through that butterfly fragment canal, perfect anatomical restoration, and 1 year follow-up, full function. Another example, a suprapatellar approach, small wound, intrapatellar region, difficult to treat, gross swelling, proximal tibial fracture, just passing a nail, and you can see here a 1 year follow-up, everything healed around the nail. Another example, a distal tibial fracture, semi-extended position, calcanean fear for better manipulation of the distal fragment, clamp-assisted reduction, use of a puller screw to centralize the guide wire and reamer, with the help of controlled traction with temporary pin in subchondral bone or in calcaneum, fixation of fibula by nail or plate, and you can see insertion of guide wire in the medullary canal in the center at the subchondral bone, and difficulty in centralization of the nail. We have to take the precaution in an extreme distal tibial fracture. You have to pass a calcaneal peel for good axial traction and indications for blocking screws. This is how we can use in difficulty of centralization, use the blocking screws so that you can centralize the nail, and it also will yield into the stability. Such an example, very comminuted fracture with a soft tissue issue. Even after 15 days, there was no healing. Restless patient, restless doctor, what to do? And ultimately, clamp-assisted reduction, central position of the guide wire in both AP and lateral, use of a puller screw, proximal and distal locking, and you can see the fracture has completely healed. Stable fixation lead to healing of mechanically incompetent but biological viable fragment to heal in a comminuted fracture. So just alignment and distal and proximal locking gives stable fixation, everything heals. Another example, extreme distal tibial fracture with a stitch wound presented after 18 hours. So instead of waiting for a very long time, calcanean pin, debridement, there was a much more defect. This fibular nailing was done. You can see here how fibular nailing was done, close method, and reaming also is done. And ultimately, fibular nailing, first guide wire into the tibia, fibular nailing, then passing the nail, and small apex neutralization by a small locking plate, nailing and augmentation plate. You can see a complete restoration of the anatomy, everything healed, and patient is under observation. Another extreme distal tibial fracture with a segmental fracture of the fibula, and this is the soft tissue. After waiting, bypassing the tunnel surgery, and there is a polar pin to glide, then centralization and centralization of the nail, and you can see here number and position of the distal locking screw is determined by the fracture morphology in proximal and distal fracture. Insert the greatest number of the screw. For distal tibial fracture, at least 3 screws and may require 1 polar screw. And for proximal, 4 screws, and you may require 1 polar screw. And you can see here, bypassing the tunnel, very extreme distal tibial fracture healed nicely with the fibular fracture also healed. Segmental fracture, suprapatellar approach, ease of performing surgery, minimal invasive surgery. It reduces the malalignment. Suprapatellar approach, protection sleeve and peak curve helps to protect the soft tissue. Shorter operative time, improved postoperative function. Despite previous concern, this technique has not been associated either a cartilage injury or increased postoperative pain. Suprapatellar intramedullary nail technique lowers the rate of malunion in both proximal and distal tibial fracture, and it is one of the now a very favored method in the segmental tibial fracture. No need to change the position of limb after the reduction of the fracture. Suprapatellar nail is a friend in need, is a friend indeed in a very difficult situation of the fracture management. So thank you very much.
Thank you, Dr. Gadegone. I'm really mesmerized by the fantastic reduction, perfect nailing procedures for all these difficult fractures of tibia. Wonderful display of all your technique. Any questions to Dr. Gadegone? I think all are mesmerized with your talk on this distal femur nailing. And with this, we can move on to the next lecture by Dr. Gaur sir. Gaur sir, can we invite you for sharing your screen and please proceed with your lecture.
Dr. Gadegone has to unshare, I think. It is not sharing.
No, you can share your screen, no problem. It's already unshared. On the bottom of screen, you'll be having a share screen.
Yeah, press that. It is showing Chrome tab. Choose what to share.
Not able to share? Dr. Gadegone has already unshared. Therefore, we are seeing the video.
I'll just
Just take your own time, sir. No problem.
Yeah.
In case you find difficulty, we can take Dr. Naveen Thakkar's lecture and then you can take.
No, I think just wait for a second.
Okay, okay.
Okay, can you see it?
No, not yet.
It has come to my screen.
Dr. Naveen, any suggestions for Dr. Gaur, sir?
Yes, just he has to save the screen in the middle lower and then select the whole desktop, not the only PowerPoint. Gaur sir.
Yeah, I'm on the.
आपको जहां हम लोगों का फोटो दिखता है ना, हम लोगों का वीडियो दिखता है, वो सिलेक्ट करो स्क्रीन.
Yeah, okay.
Then you will be able to share completely.
आपका फोटो सेंटर में दिख रहा है. Now I share the screen. Yeah. It is saying choose what to share.
Yeah, choose what to share. There you select the whole desktop.
Entire screen.
Entire screen, yes.
Okay.
Then once you select the entire screen, you select your PowerPoint.
Entire screen you are seeing, but okay.
Choose the PowerPoint. Where is your PowerPoint, sir?
PowerPoint is on the desktop.
So first you open your PowerPoint. First you open the PowerPoint on the desktop and then share the screen.
Okay.
That way also you can do.
Same way you should.
I have opened my presentation.
Yes.
And then?
Now you have a green button lower down in the middle, or it may be in the upper, your share screen.
Then I have to go to the share screen window.
You have to go to the Zoom. You have to go back to the Zoom meeting, where the Zoom meeting is.
Okay.
Share screen, and you can either click on the presentation or the whole screen.
Okay.
On your phone, if you can share the video of your screen, sir, that also we can guide you.
Yeah. What you are seeing on your screen, sir?
I'm seeing choose what to share. So
Yes,
I've
then
chosen
then
an entire
then
Click on one of
screen.
them.
then you
Click on one of
then
them.
you choose the desktop or a whole screen,
And then click
and
on share.
then the right lower side there is a small button of the share. Again, you have to click that share.
Okay. Not doing anything.
Okay. By the time you can do one thing, Dr. Thakkar, you can share your screen. You can start your presentation.
Okay.
By the time I think we'll sort out. You can share your screen, sir. Yeah, no problem.
Okay, I'm sharing.
Yeah, yeah. Dr. Thakkar is going to speak on invisible instability. Is it a cause of failure for fixation? So that is his favorite topic as well. Invisible instability.
Now you are able to see by my screen.
Yes, we are able to see your screen. As well as your wonderful photo.
I'm adjusting everything.
Okay.
So now you are able to see that.
Yes. Please go ahead.
Let me click the next slide. Yeah. So it is about the invisible instability in the proximal femur fracture. Why, how, and when. And it is a biomechanical insight, a thought process. So we will be just thinking about this thought process. This thought process started when we started experimenting in 2001. And we applied for the patent. And you can see here that we started doing the augmentation through the triflange pins where holes were made. And the augmentation was done with the cement here. And that initial cases, we did it like this. We thought that there is a rotational stability problem only. But that was not the case. It is a complete instability. This is the disclosure agreement with Synthesis for injecting the cement in the triflange pin. The idea. But after this, what we found that there is a subset of the unstable extracapsular fracture, where along with the medial instability, there is also a lateral wall instability here, if you see. And that instability leads to the many problems. And that can be think of by the literature that there is a cutout 3 to 27%, there is a medial migration, there is a lateral migration. So this is something instability even after the fixation that has to be thought. We feel that we are fixed very well, but still it is unstable, which we are not able to decide for a particular case. The stability, instability level is different. So let us start with the first case. You can see here, surgeon has done a good job. Dr. Santosh, are you there? Santosh?
Yes, sir, I am here.
Here the surgeon has done the fixation with the nail. Good reduction, 130-degree right implant choice, perfect placement. And you can see the anteromedial, there is a positive reduction here. You can check here. That there is a very good positive reduction here. But still, what will happen it? What do you think? Dr. Santosh Singh.
Yes, sir.
You have operated this case.
As
Let
Naveen,
us see what is happening in the follow-up. At the 8 weeks, the patient came with this mild varus, nothing to support laterally, toggling, and the medial migration. It is not a collapse. It is a medial migration of the implant into the hip joint. There was a lateral tension band breach here, if you can see very well, and that has been revised. Again, another case, similar type, and it was fixed and it has gone into the varus on a cyclic loading, and that has again a medial migration into the hip joint, and it has gone into the negative reduction. Now, after in the follow-up, right? So there is an instability even after the fixation. That is the problem. The best surgeon, best implant, best reduction, best placement, still there is a failure. That is the problem area. It is a very low subset of the patient. So what are the issues? It is the invisible instability even after the fixation. And the concept of the lateral tension band. and unwanted collapse pattern. The migration of the neck elements are happening. Why this is happening? That is a question mark. So we try to study this biomechanics with the Bergman. He has a lab where he can put a different these conditions where sitting in the bed even was creating a very high force in Fy, Fx, Fz axis and resultant F force. So there is a continuous force is going on. The maintenance of the antiversion, if the antiversion is not maintained, also he thought that there is a loading pattern change in the proximal femur. And here we were interested here in the junctional area where there is a shear force, varus force at the junction of the nail and the screw at the fracture level. That interface was the most important part for us to study. And we studied that there is also a vector and it is a moving on the flexion and extension of the hip. If you see, it is moving. The whole head rotates, spins on a flexion and extension rotation, or a flexion and extension of the hip joint. So there was a large dynamic and cyclic load even after the fixation from the different directions. And it behaves very differently in different postures of the patient and during daily routine activities. So when it will collapse, when it will fail, many times it creates a problem in our practice. So it is a dynamic problem. And that cannot be seen on the static films, on the C-arm static films or our routine films. So what is a lateral tension band? It is a very dynamic concept. Let us try to understand. It is not only this is the lateral wall, but the trochanter and the abductor all combines into a lateral force. There is a lateral force, lateral tension band. If you see this case, here lateral tension band was broken. If you see, lateral tension band was broken and it was a thin wall here and the DHS done, and that has given a further damage and lateral tension band has broken. But surgeon was happy on the day 40, Santosh Singh. It has medialized very well and it has gone the stability, bone to bone, good contact with the collapse. Maximum collapse has happened. You can see here. And the surgeon was happy. Are you happy, sir, Santosh ji?
Sir, initially it was good.
At day 40, what do you think?
If you want to manage this situation at this stage, what could have been done?
2 minutes रुक जाओ.
Santosh ji,
Sir,
आप क्या सोचोगे? What will you feel at this condition? At the day 40, your patient is there and you are operated and you are thinking that there is a good valgus. You can see it's a very good valgus.
yes.
It is a good medialization.
Yes.
The nature has done some job. As a surgeon was feeling well. What do you feel as a surgeon?
So I think I would add a medial TSP.
Right.
But
what Dr. Santosh Singh is telling, at this stage, are you not happy because already the God has given the stability by medialization?
Yes. So let's see
Right?
what
But
happens.
let us see. The example here is why, because still the forces are acting even after the fixation. You can see this. At day 70, it has failed because there was no lateral tension and the maximum collapse has happened. Now it has become almost a fixed angle implant. Now it is stuck in that position and that has given a problem. So what we require is a lateral tension band for preventing the varus and medialization. So you require something on the lateral side. If there is a lateral side is also gone, there is an instability. Otherwise, this will happen like this, medialization and nothing to support laterally. So you need something to support on the lateral side, and that is the way you can control the all instability here. You can see here what is happening. Once you fix it with the TSP, with the DHS, and you can see that there is a good active dynamic valgus force, which prevents further varus of the proximal fragment and the middleization. But what happens in the nail? What happens in the lateral tension band? When lateral wall is already intact, whatever drill hole we make, that is coaxial with this barrel in the nail, the hole in the nail, 130 degree. This is also coaxial. But once this lateral wall is broken, whatever screw you are putting, they are not coaxial. And what happens exactly here, that it starts toggling. And once it starts toggling, you get a instability and you get a Z effect or a reverse Z effect. Santoshji, you've seen this in your two elements of the neck, PFN, classical, Z effect and reverse Z effect, right, sir?
Yes, sir, right.
But we were not knowing why it is happening. But what we studied, that why it is happening, it was happening in the single implant assembly also. If you see, toggling is happening here also. But here, because of the good hold in the head and neck part, it was going medially. So on the toggling, it goes in. So either there is a lateral migration or a medial migration. There is nothing like Z or reverse Z effect. In the two elements, it's our visual impression that it is a Z or reverse Z effect. In a single element, it goes in unidirection. Either it goes in or either it goes out. But what we observed, that the part which has a good fixation here in the head and neck part goes in. It goes in always. The part which is not holding in the head and neck part comes out. That was the observation here. So now let us see another case. Santoshji, what will you do in this case?
Sir, actually, it is an unstable type of fracture.
Yes.
Fracture, so we go for the intramedullary nailing.
Intramedullary. Okay. The surgeon has done the same job. Can you predict what will happen? See, you can see the reduction is good. Here it is a positive reduction. Here it is also good anteromedial contact.
Till it will not, it will fail.
It will fail. You are right, it will fail. But I am asking Dr. Santosh Singh, what will happen? How it will fail? What will be the mode of failure? Whether it is a cutout, varus cutout, Z effect or reverse Z effect?
So Z effect.
It will be a Z effect. So you feel that the lower screw will come out and the upper screw will go in, or upper screw will come out and lower screw will go in.
Upper screw will come out and inner will go in.
Let us see what is happening. It is a M or W effect now. You can see it is a M or a W effect. This is the effect. Both have come out. So there is nothing like a Z or reverse Z effect. It is an instability even after the fixation. This is the invisible instability which we are not able to judge on the table and many times in the initial follow-up also. And this gives us a surprise by giving this such a failure by lateral migration of both the elements.
But this does not happen in every case.
This does not happen in every case. That is why.
So how to detect? How to detect on table?
How to detect on table? That was the question asked by Dr. Ajith, sir, I think.
Yeah.
So in a fracture table, what you have to do is you have to just release the foot pad from the fracture table and try to rotate and see in the dynamic film. There will be some jog of movement. There you have to augment. And that is the key to understand the instability in such case. There are multiple variables because probably the TAD was not also good. If you see the previous
varus was there and TAD
of this
not good. That's why
TAD was not good. Bone quality may not be good.
There are
multiple factors. Yeah. Multiple factors which were leading to instability. And the forces were acting in such direction. Varus was not a problem. Here it was a positive reduction. You can see. We cannot say it was a varus because it was a positive reduction here. The next half angle is right. The screws are going exactly in the parallel. If it is in the varus, it will go in the upper quadrant.
Moderator, sir. Moderator, sir, may I interrupt?
Yeah,
Yes,
please,
yes, sir.
please.
Sir, I have actually, this is a famous lecture of yours.
Yes.
I have no doubt about your study and everything, and it is in practice we are doing whatever the you give the instructions. But when you treat the fracture is when treated by osteopath, and there is so much instability, still the fracture united. Non-union is virtually unknown in a osteopathic treatment in a trochanteric fracture, whereas so the fracture is unstable, fracture is in varus, fracture is in external rotation. Still, it throws a very beautiful callus.
You are
and
right.
fracture
You
unite.
are right. So we are restricting the callus also, and we are not putting in that position. That's why it gets malunited with the bone setter, but it gets united. You're right.
But why if the unstable fracture pattern is there, and when you do a minimally invasive surgery also, it does not throw any callus and union also? Why?
Because there are a lot of movements here, toggling, and there is a restricted things are there. The muscle forces are acting, but muscle forces are not allowed fully. In an untreated case, many times the muscle forces take the care without any implant. That may be the probable answer, I think.
Dr. Naveen, I think the surgeon didn't do a perfect nailing here.
Yes, I said you that this is the operated case. You said that probably, yes, you are right, absolutely right. But there is an instability even after fixation. We feel that there is we have made stable many times, but it is unstable. We'll go further where the surgeon is not doing any fault. Still, you can see what is happening there.
So at this point,
So
Dr. Chandak's question is pertinent. How we know the instability?
We'll go to the next case, then we'll discuss that part.
Okay.
So why it is happening? Why there is a toggling? So we try to study it, and the scientists have also studied the biomechanics of the snake movement. It toggles with the friction on the ground. It has no legs, but still it toggles. On the toggling, it can move forward. You must have heard the story of K-wire migrating even into the heart. How the K-wire alone migrates? Because there is a continuous toggling with the muscle movement, and that advances further and further and further. That is a ratcheting effect. So this was the problem of ratcheting and toggling, and that was the instability indirectly. Let us see what is happening now. What you say in this case? Surgeon has done a Halifax nail. Chandak sir.
Yeah.
What do you feel? Surgeon has done a right job? Here you can see it's a positive reduction. Reduction is very much positive here. If you see, it is a positive reduction here.
Right.
There is no problem here. Anteromedial, also good contact in the lateral view. You can see that.
Yes.
Entry is through the fracture site. Entry is not right. So it's likely to give problem.
Entry is not right. Okay. So many times our entry remains from the fracture site.
So
it's a very osteoporotic fracture, right? Now let us see what is happening in the follow-up. This is the follow-up. Positive reduction at the 8 weeks. What do you think now? Though the entry is from here, it is all comminuted here. There is a great bowing of the femur in the old age.
Yes.
There is a positive reduction here, and there is a good anteromedial contact. What we understand that once we get a good positive reduction and bone-to-bone contact, what do you think? What will happen? Santosh Singh, Ajith sir?
I actually think the nail is bored the wrong way around. Looking at this, so there must be some technical problem there. You see the bowing. Normally, you get a anterolateral bowing. Here, it seems
it is anterolateral only, sir.
No. You see the shape of the nail. It's going towards the lateral cortex here.
Yes, it goes the lateral cortex only because of the too much of the anterior curvature. It is touching the anterolateral part. You're right, absolutely.
I think wrong side nail is put on.
Yeah, I
Left
think
side
that's
is
what
put
has
on
been
the
done.
right side.
Yeah.
Wrong side nail has put.
Yeah.
Anyway, that may not be the reason for the failure.
You cannot fix the 130-degree helifax with the wrong side.
Why?
How can you put?
If you
In a
reverse
short,
it,
in a short nail, there is nothing like right and left, sir.
Yeah, correct. It is a universal nail. It's
It
right.
is a universal nail. There is nothing like right or left here.
but this nail looks bored. Anyway.
Yeah.
So you are looking something odd at the nail, right?
Yeah.
Yeah.
But what do you feel? It is a right and left is same helifax nail, and it is a good prong here. If you see, it is a good prong and it is a good fitting here. And this is at the 8 weeks.
So otherwise this looks okay, except for your lecture on instability.
No, because of the bowing, it may still go cut the superiorly going into varus, but everything looks fine for me. Means I'm okay with this reduction and this position of the screw, everything.
Right. Anybody has any objection?
Except the bowing, which you don't and I don't have control.
Okay, don't have any control. Surgeon has no control on the anatomy, right? So now this is the case from the literature where you can see that what has happened. The concept is on the toggling, the neck element has not gone in a linear fashion. It has gone like serpentile, and it has created a big bogda here. Big bogda here. You can see it's a big bogda. So the toggling happens and the movement of the neck element was happening like this. And it has gone even into the pelvis after the head. So these forces are acting continuously, and you can see here that it has gone inside the pelvis itself. So what is the possibility? This is the case of the biomechanical analysis of this case.
In this case, Dr. Naveen, if the fixation would have been with DHS, would that not have been more better for this patient? Would have avoided all the problems?
But anyway, instability was there. Even after the fixation of the best implant with the helifax and a good TAD, everything good reduction, positive reduction, everything was good, sir. But still there was a problem because there was the instability remaining which could not be detected on table. Now what the concept is from the snake biomechanics, scientists have studied this, the biomechanics of the snake. If you see, there is a movement of this on the toggling, right? If you remove the toggling, what is happening? How to remove the toggling in the movements of the snake? They found that if we put a very smooth plastic material wrap around the snake, it toggles, but it doesn't move. You can see here in this video that it will rewind now. It toggles, but it is not able to move further. It toggles at that place only, but it doesn't move. Right? So same concept to reduce the toggling, and you can get the stability and movement of the neck elements, unwanted collapse pattern can be prevented. That was the possibility biomechanically. As you can see here, toggling, because the ratcheting effect will go away. There won't be any ratcheting on the surface and traveling of the neck element. So this is just a thought process. Recording is stopped.
Good resume.
Okay. There is an unexpected collapse pattern which is in the literature, and we do further large screw drilling here. If you see, we are drilling here a lot, and we are making it more and more weak. And that's why there is a problem. And the jig, our jig has also a problem. If you want to target exactly the center of the head and neck, we have to rotate it externally. And rotation of this external rotation, many times we have a breach here posterolaterally. And we have a very small incision, we don't feel it. And we make this posterolateral wall more weak by drilling here in the posterolateral part, because we want to adjust exactly in the center of the head and neck. And the same way on the rotation, when there is a bowing in anterolaterally here, the stress riser effect is created in the shaft. Pointing effect is created. So we must have a jig which has a two plate, where this goes exactly in the center of the head and neck with the anteversion, and the shaft should go exactly 90 degrees, like this. It goes exactly in the center, maintaining the anteversion. And maintaining the anteversion has also a very good biomechanical advantage. You can see this is the pre-op, this is the nail, this is the post-op. How beautifully the anteversion is maintained on the both sides. And that gives the equal distribution of the force. And that becomes the destructive force, becomes the constructive force. So we are unable to preserve the lateral tension band when it is broken already. We have all the literature here. The proximal lateral wall thickness is a problem. All studies are there. And this is the benchmark study for the DHS. Intraoperative breach of the lateral wall and the post-operative breach of the lateral wall. After DHS, even post-operative. Later on in the follow-up, there is a breach seen. And 32% problem has been reported with this benchmark paper. And the Gottfried started with this plate where there was a additional here to support the lateral wall, and he reduced the size of the screw and he put a barrel inside so that the gliding becomes smooth. Another paper with the lateral wall thickness, DHS alone should not be done. So these are the papers. So we have to protect and re-establish the lateral tension band by adding the cooperating the one more implant in such an unstable condition. Here is the one example here, schematic, where the nail and plate combination works in a cooperation. Another case, again, you can see there is nothing to support laterally and screw goes through the nail, through the plate. And here also the screw goes through the plate, through the nail. And that gives the complete fixation, and the greater trochanter is wired. So the complete lateral tension band is taken care of. The force on the lateral side is taken care of. And that gives the complete stability. Another example, I will not go into detail. This is a long video of the live surgery. It's not going further. Okay. Another case, DHS, and that lateral wall is broken with the DHS and the medialization and the problem. Again, this method has been used. And you can see here beautifully that there is a negative reduction. You can see there is nothing to support here on the medial side. If you can see that there is a negative reduction, right? But this screw is touching the calcar. So valgus has been kept. What the neck shaft angle is, because this goes parallel to the calcar. And there is no anteromedial contact. But once you give the stability, adequate stability, and then the bone starts uniting. And this bone got united very well. And this is the follow-up. And it is remodeled also at the 2.5 years. And you can see how beautifully the medial wall is reconstructed by the nature itself. One should take care of the stability. So the stability is the issue, whatever implant you use. So do we need a union only? Or what about the function? We were happy previously with the medialization. We were thinking the medialization is good. Then we thought the medialization is bad. Then we thought the medialization is very ugly. So we don't want this. Now patients don't want, because patients are suing our orthopedic surgeons for just a simple lurch. Criminal negligence cases are put. But the literature is confusing about the variety of the unstable fracture. There is a mixed bag of the instability. We have to think for such. And this is the video from Dr.Tanna sir, where you can see on the rotation or a flexion and extension, you can see the fragment is moving. So you have to check intraoperatively whether stability is there or not. And you feel whatever doubt. This is again a case of Tanna sir, where on table he thought that I have to add this. So he added the periprosthetic hook plate exactly putting on the trochanter completely, and just made a wire and a unicortical screw here. But still it has given a good stability. So you have to be prepared on table. So when in doubt, feel instability even after the primary implant insertion, be prepared or anticipate for augmentation, whatever implant system you are choosing. So the message is detect and the preserve, be aware of the lateral tension band concept and the protect the lateral tension band when it is already broken, and always try to bring back the abductors. Think of the dynamic stability and restoration of the complete lateral tension band, because the piece of this trochanter, which is a soft tissue attachment, also brings the vascularity there to add to the healing of the bone. Again, I have a small appeal to all the members of the Indian Orthopedic Association. Update your data. And now we have started the verifying the Aadhaar of the each and every member. So you can go on the website and log in, and you put your Aadhaar number and confirm your Aadhaar details. So you will become the Aadhaar verified. We'll put the video and the PDF file how to do it, but it's very easy. And those who are listening, not IO member, as a duty of my as a secretary, please join us in the IOA. And again, we invite you at Lucknow for IOCON 2023. And in the CME, we invite, because the theme is again the innovation, technique, paper, or a case or idea which may change my practice, may change your practice. So please contribute your ideas, new things which may change my colleagues' practice, may help my colleague to change their practice, and ultimately it gets the advantage to the patients and the as a whole society as the Indian Orthopedic Association contribution. Thank you very much.
Thank you, Naveen, for
Thank you,
that
sir.
wonderful concept of bringing in instability for failures of intertrochanteric fractures. That was wonderful video demonstration of the instability and the serpentine effect leading to further extrusion of nails, Z effect, Z effect, M effect, and W effect. Any
Recording
questions?
क्यों बीच में बंद कर दिया ना, फिर अभी चालू किया.
But it was streaming live. So
It was streaming live. Sir.
I checked.
Gaur sir, ready?
Gaur sir का हो गया.
Dr. Gaur has a
presentation
question.
ready हो गया.
Yes.
I'll share and see. I have a question to Dr. Naveen first.
Yeah,
Yes,
go
sir.
ahead.
Yes, sir. Yes, sir. Yes, sir.
I think this plate, the plate he has devised, the hook plate, they give stability to bone.
Yes.
And bony stability is more important than soft tissue stability, what he's talking about, dynamic. See, when you move the hip to lateral side or abduct it, the soft tissue relaxes. So stability goes. When you adduct it, it gives more stability. So it is not actually the gluteus medius or the dynamic which is working. It is the screw which is fixing into the head, like DHS or PFN. Now, when you do the PFN, if your screw is very tight, you know it is not going to do Z effect or M effect. If the screws are not very tight, and as rightly Naveen has said, there is inherent stability is remaining, then there will be movement. And the movement, any nail or anything will loosen up. So it is the screw which is going through the plate into the head actually gives more stability, which makes the fracture to unite. What Naveen has to say.
Yes, yes. Whatever instability was remaining, that was augmented with the plate. And I have a reverse question to you, Gaur sir. You said that the soft tissue or trochanter or abductor has no role. What do you think about the dislocation?
Little role.
Dislocation of the hip when the abductors are not taken care of. The biomechanics is such that there is a varus force continuously happening that is going to reduce your neck sub angle. And there is a lateral force which keeps your neck sub angle. So lateral valgus force has to be re-established completely lateral tension band with the bone and the muscle, everything, sir.
Thank you.
Dr. Naveen, which plate you prefer for the fixation majority?
Sir, still we have not made it commercially. We are doing for us only because still we have our remaining part of research and the biomechanical study. We want to get the rotational stability between the neck element and the nail hole.
Yeah.
And that is very tricky. So there we are stuck. Till that we get a solution of that on our prototype, we are not going to get manufactured it.
So sir, every time you try to fix one screw through the plate and whole plate and nail both, or in a different direction?
So sir, the plate design is such that it cooperates with this nail design only. This nail design is such that the holes in the plates are also such that it goes through the plate, through the nail hole. And also the proximal locking, transverse locking also goes through the plate. Transverse locking, that is lateral to medial, also goes through the plate, through the nail hole, through the jig.
Okay.
संतोष जी, don't worry, लखनऊ में सब बताएंगे आपको.
Can you see my screen?
Most welcome, sir.
Dr. Chandak?
Yeah, thank you so much. And
One
now
minute, Chandak, I have a question, Naveen. Naveen,
Yes.
you said
you
that
see
the
my screen?
instability is the main reason why we are getting all the problem. This instability, can we reduce it by using a neck screw which has got a head? Because you can compress it totally on table. There is a head which acts as a counter support. You can compress to your satisfaction. Whatever the complication you have shown, the screw migrating into the pelvis, they are all headless screws. Those screws cannot be compressed. Though you put a set screw from the top to lock it, but the lateral wall is still able to move out because there is no head for the screw.
You're right.
So do you think that the neck screw having a head is far better?
Yes, always. We always use the head screw when there is a small breach in the lateral wall. We use the cut washers. The cut washer with the head, and that cut washer with the head, that cut washer, we can drop the cut washer on the guide pin at the cut, and then we pass the screw with the head. But when it is broken very badly, the screw head will rest to the nail only. Toggling cannot be prevented, sir.
If that is so, then why we are not, the newer implants are having headless screws then? All the PFN-A2, ZNN.
Because they think that the heads are probably, when it come out, it may irritate the patient skin on the lateral side. So they are doing for the different reason. But we have to have something to support on the lateral side. Suppose you are fixing this fracture neck femur and you are doing 3 cannulated screws. You always put a washer. Even the lateral wall is intact because you cannot compress without that. Here in the unstable fracture, there is the bone is broken like this, and you cannot compress because the collapse and the compression cannot coexist together biomechanically. When the fracture is collapsible, fracture is not compressible. When the fracture is compressible and compressed, it cannot collapse.
So with those concepts about instability and difficulties of intertrochanteric fracture healing, let us move on to the next lecture.
Yes, complicated soft femur. Yes.
Yeah. So Dr. Gaur is waiting for his talk on complex, complicated fracture shaft of femur. So please proceed, sir. We can see your presentation.
Okay. So I thank you, Indian Orthopedic Association and NAILS Committee for giving me this opportunity to talk on complex, complicated fracture shaft of the femur, a common fracture with the strongest bone. When it breaks, it causes problem. Winquist has classified this from 0 to 4 in 5 category, and the 3 and 4, where the contact between proximal and distal fragment is less than 50% or there is no contact, they are classified as complex fractures. You can treat them conservatively or operatively, but as the literature of the last few years is showing, the displaced or undisplaced fracture shaft of the femur, be it simple or complex, given better outcome with the operative treatment. It's not that if you treat them conservatively, it will not unite. It does unite, but the patient has to be on traction in the bed, and the functional problem is there. There may be shortening and things like that. It is also not true that the standard treatment of interlocking nail will give success. It has about 12% complication rate, and implant can break, fracture may not go into union because of other factors. So a large series was published of 1,300 patients to see the outcome of femur shaft fractures. And they have seen that the success rate is more than 90%. However, in 10% of the patients, there were still complications like non-union, delayed union, infection, and other factors. But they have compared it with some other methodology like Anders nailing and plating, and said that the gold standard is still intramedullary nailing locked. So this fracture, which is straightforward two-part fracture, the treatment is standard nailing, interlock nailing, and it gives a good result in majority of the patients. What are the options? The options are nails, which are various types of nails. The plating, X-fix, obviously X-fix is used in compound fracture. Plating has gone out, and nailing is still the commonest mode of treatment of these complex fractures. So what are the issues? Static versus dynamic locking. If the fracture is transverse or short oblique, the dynamic locking can be done. Now the nails are available, which has dynamic hold distally also. Also proximally, most of the nails have dynamic locking. So the longer the fragment where you should use the dynamic locking and allow early weight bearing to have early union. However, in complex or comminuted fracture where there is a instability, the static locking or two proximal and two distal is the principle. Timing of surgery is within 48 hours as per the concept as we have discussed earlier in this webinar, and early surgery is better than waiting later on. So if you have a comminuted fractures, it is stabilized with the nailing, but there are fragments which are not actually reduced well. And if you leave the gap in the fracture fragments, you are asking for trouble. Like this patient, the fracture did not unite even 6 months post-op surgery. So what should have been done? I think open reduction and holding these fragments back into place will have given union much faster. Reduction techniques are very important, and it's very interesting how you use them, and that's make the surgeons different from each other. One achieves it in an easier way, the other struggles it. You can use a supracondylar pin, as Dr. Gadegone was showing for tibia. He uses calcaneum pin and put a long bolus strap and attach to the traction device. I use the fracture table for these fractures. The F tool is also an important tool to keep in the OT for reduction or helping in the reduction of these comminuted fractures. Femoral distractor is very useful device to help you in reduction. You can put one pin proximally, one distally, and then distract it. It gains the length reduces the fragment, makes your nailing easier. Butterfly fragment in a comminuted fracture, which one is significant, which is not significant? I think if there is no contact between proximal and distal fragment, as shown in this patient, there is no contact between proximal and distal, you should think about open reduction. If the contact is less than 50%, then also open reduction will be better. If fracture gap is more than a centimeter and shortening more than 2.5 centimeter between these. So all this is present in this case and is supported by the literature that it causes problem and causes a more reoperation rate. So if you don't shrug from opening the fracture, reducing it well, and then dropping the nail, if there is instability, putting a plate over it. There's another patient where the split fracture of the middle fragment is there, segmental fracture. A lot of gap is left between this, and it is asking for trouble. The fracture did not unite 6 months post-operatively, and there was some infection also. Obviously, pathological fracture, intermedullary nailing is a standard procedure for palliative purposes, and you can't use a plate. Now, I'll show you some cases. This is a lower third fracture extending suprapatellar area where it was used, retrograde nailing was used, as discussed with Dr.Shivashankar, that suprapatellar nail is coming back. But don't leave the gap in the proximal part of the femur shaft. It takes a lot of time and goes into delayed union. So since the canal is wide, the fixation is only subchondral in the distal part and in the proximal part. Middle part, where the fracture is, if there is a gap, open it and you can stabilize it circulate wire. There's a lot of papers which have come up, which are using with open reduction, circulate wire in antegrade and retrograde nail, which helps into union. Non-union is well known. We have said that what to do if it fails to unite. The three simple principles, whether it is vital or avital, whether it is septic or aseptic, how is the condition of soft tissue? They determines how you deal with these failed fractures. And you learn from each failed fracture what proper treatment should have been done in previous scenario. This 28-year diabetic patient had a septic, aseptic, avital. Initially, he had sepsis. He was treated by various treatment, like first femur interlock, then femur interlock was removed, external fixator was put in, femur plate and fibula graft was given, and then removal of the plate was done. And this was the condition he presented to us. Now, Dr. Tanna has talked about this augmentation plating and supplementary plating. And I think we are moving from more movement, biological movement, to more rigidity when we treat non-union scenario. Whether it will be true in initial scenario or not, I don't know. But this patient who was 4 years old, multiple surgeries, exchange nailing and a supplementary plate was put on, and it has gone into beautiful union. So if it works in non-union scenario, it should work in fresh fractures, but yes, you have to select the patient. This is a atrophic type, aseptic, avital, 55-year, 3 years back, atrophic non-union with broken implant. Exchange nailing and augmentation plating with the bone grafting, since it was avital, was done and it has gone into union. There's a 15-year-old patient where K-nail was done. It is hypertrophic of the non-union, the implant is broken. a nailing, interlock nailing was done with a supplementary plate, and it has gone into a non-union. In patients who present to you late, their medullary cavity is very wide, and we don't have the nails to stabilize it. We don't have the nail more than 12 generally available. So you have to supplement with some other plate to augment it, because nail will not with adequate stability. So in this scenario, later when the patient presents to you, supplementing the plate is a good idea, and it gives you union. This is a complex fracture which is put in with the interlock nail essentially wire. There is still instability, and the screws broken and all. And exchange nailing was done with a supplementary plate was put on, and it gone into union, although there was some shortening remaining. So we have published a paper from Bhopal in 2017, augmentation plating in management of failed femoral nailing. And it has shown that supplementing the plate over a nail is a good idea in failed femoral nailing patients. Operant treatment of femoral shaft non-unions also said that stability is important for these. Femoral shaft fractures, non-union, the stability as well as the vitality both are important. So just to sum up, history is very interesting of each case and important in the management of femoral shaft fractures. You learn from each case why it has failed so that you don't do it next time. Prognosis of fracture not only associated with bony problems, but largely it is going to be a soft part or around the fracture, soft tissue is also important. Intramedullary interlock nailing is still the gold standard in complex fractures, although some percent of the patient does not go into complete union and function. Exchange nailing is effective, but it's better than bone grafting when you do it initial few months of the fracture delayed union. Augmentation plating is effective in femoral shaft non-union treatment. Don't leave the fracture gap. If required, don't hesitate in open reduction and fixation. And I think this is a very important concept which is coming up, that we had gone to close. Now you have to close open. Both things should be done in an individual case. Successful surgeon is the one who not only learns from his own mistakes, but also from others' mistakes. Thank you very much.
Thank you, Dr. Gaur, sir. It was a wonderful presentation. Sir, I have a query about this. What you prefer in the non-union, either the exchange nailing or plate augmentation?
Gaur sir, please unshare your screen.
I will ensure and answer that your question. No, you have to put both. You have to do an exchange nailing and then supplement it. If possible, if the fracture is allowing, you extend it to one of the corners, like superior trochanteric area, or if it is lower third, you put it to condylar area, plating. So alone plating will not work.
And sir, what you decide whether you have to bone graft at that time during application of the plate, or it will suffice without bone grafting?
It is pre-op decision. When on X-ray you see whether it is vital or avital. If it is vital, you don't need it. If it is avital, you need it. The other thing I will tell you is another point is when to supplement, initially or later on. When you fix the fracture with a nail, and if the fracture site is open or you have opened it for bone grafting, you rotate it. If there is some rotation at the fracture site, that is the time when you must put a plate, otherwise it will fail. If there is no movement, you can get away by the nail only, exchange nail, thicker.
So the only nail and interlock may not give the stability. Again, there is an invisible instability, rotational instability that you have to take care by the another implant.
Exactly.
And particularly with the osteoporotic patients, always span from greater trochanter to lateral condyle fully. Otherwise, there will be a stress fracture. Yesterday, we saw the example in the Indore, Dr. Nina.
Negi.
No, not Negi, Nima.
Nima.
He presented a case where in an osteoporotic patient, he did a fixation. Then there was a fracture at the end. Then again, he added a plate. Then there was a fracture again at that end. Then again, he did a plate and he kept the space between. Third time, it was fractured. So you have to span fully in the with the nail and the plate.
Yeah.
When you are in doubt in the osteoporotic fracture.
Sir, what should be the protocol if there is a non-union in an interlocking nail and you have to go for the exchange nailing and it is a closed procedure? So now how you decide there is an instability, invisible instability, and you have to put or augment the plate on it?
Yes,
That's what I said. That's what I said. That if it has gone into delayed union non-union scenario, like I've shown you 4 years, 15 years, no, like 6 months, 8 months down the line, you exchange it, put you ream it minimum 2 millimeter more, you put the nail minimum 1.5 millimeter more. Once you have locked it statically both sides, you rotate it. And what Naveen is saying, there is invisible instability. You can see between two fragments that it is moving. At that time, you must supplement it to give more stability. Otherwise,
I think Dr. Santosh is asking how to know when he is doing a close exchange nailing, whether there is a rotational movement occurring or not. That you have to shoot dynamically on the C arm.
Yeah.
And you have to see the matching of the cortex. While doing a dynamic rotational stability, if you feel the thickness of the cortex is changing, then there is a movement.
True.
You have to see the thickness of the cortex. You can see only the thickness of the, many times you may not see the gross movements, but you have to see the thickness in the C arm.
So could it has been neutralized by the fixation in the two plates?
More important dictum is when you are in doubt, you support extra. There is no problem of overkilling, little bit overkilling.
No, I want to ask, sir, if you fix the distal part of the nail in two directions, then still there will be invisible instability. Now, what is your experience now in
a comminuted fracture shaft, in a supraisthemal fracture and an infraisthemal fracture, with the combination always requires the extra stability. Alone nail does not work, and we have to do a secondary procedure. So you can do primarily nail and plate together if you feel like that. In a comminuted shaft, in a subtroch fracture where there is a combination, there is a medially combination. So only nail will not work, and you do not have that much proximal screw fixation, which gives the rotational stability. And many times you are not putting antero-posterior screw in the distal part, because multi-locking is there in the three screws lateral to medial. That is the same direction, but it should be multi-plane. So you have to put the antero-posterior screw in the distal fragment. Then it will give a multi-plane fixation.
Yeah.
Probably in a good bone quality and you have a good contact, without the plate it may work. But you have to take care in the follow-up, check that whether it is uniting, is there is a movement in the screw. Toggling of the screw will give the rise to the increasing the size of that hole. And there you come to know there is a instability. That is again a sign in the follow-up that whatever hole you have made on the toggling, that hole becomes little larger in your cortex, you see. That is a sign of instability again, because some movement is occurring at the interlocking level.
Thank you, sir. And now the time for the last presentation by Dr. R.M.Chandak, sir. Sir, you are welcome. and you have already shared your screen. So please start your talk, sir.
Yeah, thank you very much. After those wonderful lectures on difficult nailing procedures, I'll be speaking on inevitable, sometimes happening complication, a dreaded complication. All of us in orthopedics always we fear about, and that is early infection after a nailing, how to diagnose and what intervention we can do. So surgical site infections, we can encounter pathogens which are either endogenous from the patient's own flora, skin, and the surrounding skin, etc., or exogenous seeding of the bacteria during the surgical procedure. We may have an infection which occurs early, within 30 days of the procedure, or occurs between 1 and 3 months, or presents more than 3 months after surgery. The guidelines and surgical management of all in these situations would probably differ. The CDC classification suggests a surgical site infection can happen in the skin, subcutaneous tissue, or in the deep tissue, or including even the organ space or the fixations. How do we diagnose a surgical site infection occurring early after a nailing procedure? It would be with the classical signs like redness, swelling, wound drainage, chills, high-grade fever. The investigations we'll have to do in this case are routine, but what I would like to draw your attention is the most important fact is a clinical diagnosis. A patient who is not doing well, usually second day patient has a lot of pain after the procedure, but the third day he usually settles down completely and his requirement of analgesics, etc., go down. But when he's not doing well, he's throwing fever. We have to look into the cause of his fever, whether it is arising from any other cause apart from the surgical side. Look at the wound, and if any doubt, we have to take action. The radionuclide scan I have not yet done in our own setups. However, in the literature, that has been given as a good tool. The role of MRI is again doubtful. Very rarely would do a CT scan in this patient. The most important diagnosis remains is blood parameters, markers, and the clinical diagnosis. Usually the infection setting happens within usually 4 to 5 days of the surgical procedure, except in the necrotizing infections caused by either streptococcus, which presents within a day, or clostridial infections, where you have to, which is again a very, very serious condition. Whenever there is an infection and it is simple erythema beyond the wound, we would always start with initially the drain continues, drainage, and antibiotic. If it is just confined to skin, subcutaneous tissue, or a small stitch abscess, not any other parameters to suggest a deep infection, then possibly draining that and taking care of the wound care if it is very superficial. But wherever we are suspecting a deep infection, surgical site deep infection, it has to be a suspicion, and we explore the wound, lavage the whole thing so that the biofilms do not form, and we remove all the detritus tissue, hematoma, drain it, and even in case required, we may put a wax solution. The whole wound has to be laid open, completely washed. Many times we may not find active pus formation, but usually there is a lot of edema. All slough, devitalized tissue has to be taken out. The wound has to be laid open completely. It is not just a miniature opening, and that is usually rewarding, which would avoid a long-term infection to this patient. The other wounds, even in the vicinity of the primary fixation, can also be taken care of in the simultaneous setting. This is a case of a young male who came after his surgery done a month back, had a fixation, and started pouring pus from the distal interlocking site, and had a florid course, was running fever. In the post-op period, he was given antibiotics, but he was not settling. That was explored. The whole wound was explored complete. Since the whole medullary cavity, proximal interlocking site, distal interlocking site, everything had pus, we had to take out his implant, remove that, put an antibiotic nail even in the early phase. Usually in the early phase, when the fixation is good, we would retain the implant. However, in this specific case, I had to remove the implant as the whole cavity was full of pus. And then we had done a 2-stage procedure for this patient. Usually when we replace that with an antibiotic nail, I would usually use a 4 gram of vancomycin and either gentamicin, amikacin powder along with the vancomycin to give a good antibiotic elution. However, in the very early phase of infection, we would usually open the wound completely and debride the wound. This was another case who came from a hospital already operated for a fractured shaft femur, and the surgeon had done an open nailing procedure in a comminuted fragment where the middle fragment was actually topsy-turvy. He did a complete open procedure and had a nailing. The patient on the day of stitches removal had a very nasty discharging pus, was having high-grade fever as well. And that patient, we had to use a negative pressure wound therapy to take care of his wound condition along with local measures. So that wound was completely debrided. The whole stitch line was open. Negative pressure wound therapy was instituted first as an open vac and then with the vacuum assisted closure method. And that patient did well and his wounds healed over a period of around 2 to 3 weeks. And the healing also subsequently proceeded very well for that patient. This patient had, after nailing at my own center, had extreme pain, swelling, induration, and fever as well. And as we can see on the suture line, there was a lot of edema, etc. And his platelet counts also were quite low. The drain site also had a thick clot, and exploration revealed a lot of clots in the wound. He required hematologic management along with wound management. And then this patient also healed well and his wound settled down over a period of weeks. So friends, when we explore these wounds early, take care of the wound surrounding edema, provide them appropriate antibiotics, there will be a good healing. In the early post-op phase, my appeal would be whenever you find even a small pus or a wound not doing well, it is always better to appropriately give them antibiotic cover, explore the wound, wash, lavage, debride, complete wound management, and if required, a negative pressure wound therapy, that would give us a good healing. So we consider whenever this patient have fever, not doing well, all these factors to get a good result. Not only the wound management, along with that, the complete holistic management of the patient would be very important. And we must evaluate all the risk factors to take care of infection, which are very, very vital in our rounds when we take the history and take care of other associated factors. If there are deficiencies, deficiency of protein, vitamins, etc., those also should be taken care of along with supplementation and wound care. In summary, what I would like to say, whenever we suspect early infection after a nailing procedure, have a high index of suspicion. That is one very important factor along with your investigation. Explore early. Thorough debridement is actually the key with appropriate antibiotics so that we give a good healing to our patient. With our aim of giving complete infection eradication, which is possible with early exploration, if the wound continues to have smoldering infection with antibiotic cover, they would manifest with a complete infection of the medullary cavity later on. So do a complete initial early debridement. Our goal would be achieved when we control the infection, and the infection eradication is possible if we intervene early. If we intervene later on, the infection becomes established, and then that is just a control of infection. And if we take care of this, and if this stable fixation is there, we would usually achieve union. Simultaneously, we also have to look into the soft tissue management, joint contractures, and mobilization of the patient. Thank you. Thank you very much.
Excellent, Chandak sir. Excellent.
Thank you very much, sir.
Chandak, you talked about hair removal, but I just want to reiterate that point because you just made one point only in that slide. Definitely, earlier we were doing hair removal a day earlier or 2 days earlier, and the patient was not coming on the OT table in the as per the plan. and the infection chances were very, very high. And it's now I have made it a routine that either if the shaving is required, it will be done only after a patient is anesthetized, that too only the part which comes in the way. Otherwise, shaving is not done routinely nowadays, and definitely the infection chances has come down, because when the shaving is done, there are minor scratches which happens, and that is a potent place for the infection to happen. And many a time the routine everywhere is to prepare the part. They just write prepare the part, and the patient may not come on the next in the next 48 hours into the OT, and that gets infected. Yes.
Absolutely right, sir. We remember those days in medical colleges where a barber used to be there for
Yes.
pre-operative day planning.
yes.
That has all gone now. We
और
recommend that thing.
काफी जगह के वो एब्रेजन भी कर देता था, लगा देता था अस्त्र.
Yes.
Yes.
Incision लगा देता था.
So there are so many things in preventing
But the-
surgical site infection. So
there
all
is a particular condition, sir, that many times we get the discharge and we are worried for the infection, but it is not really an infection.
So possibly
So
a fat necrosis?
only distinction between the discharge which is painful is usually infection. When it is a painless, mostly it is another reason of hypoproteinemia, fat necrosis, or a platelet dysfunction, and which is leading to a problem. In one of your cases, you have shown that there was some hematological problem, that is the platelet count is okay, but the platelet function is a problem many times. And
So-
there you get, and you explore it, and you found that there is no infection.
Dr. Gadegone, I must thank you and appreciate your hard work on the book, Getting OT is My Temple. And
Yes.
Dr. Chandak, I'm thankful to you. I have read your both the topics, essential adjunct and bailout instrument in OT. It was a beautiful, beautiful written, sir. I must thank you to you for this, providing me this booklet. And I request you to further write down the same things which are very helpful to a general orthopedic surgeon.
Thank you.
Santosh ji, we had done a series of webinar for this series of webinar.
Sir, it was a beautiful book. So it was a great effort by Dr. Gadegone, sir. And at this point, I must congratulate to both of you, sir. Thank you so much.
And this book has been published in the IOCON inauguration, sir. It is.
Yeah, I have seen at that time, but later on I have received from Dr. Gadegone, and I have read it. It is a very beautiful book, sir. Very well compiled, sir.
And if you see all the webinars recorded, you will come into the more and more details, practical with the photographs and everything.
Dr. Chandak
sir has done a lot of work on that.
Yes.
So with this, I think we have come to an end of the webinar. Thank you everyone for joining.
And Chandak sir,
yeah.
Chandak sir, next episode is on upper extremity complexity of nailing.
Yes, absolutely.
That is the theme, Naveen bhai.
Yes.
Our theme will be in the next webinar, complexities of nailing in upper extremity.
It will be a very debatable, sir, in upper leg.
वो debatable तो रहना चाहिए ना, debatable नहीं. So I thank all participants, especially Chandak sir, Shivashankar sir, Santosh Singh, Naveen bhai, and all these faculty member, Naveen bhai, Trikha sir, Ajith Kumar, Shivashankar especially is helping me all the way, and Dr. Sanjeev Gaur. And these are all faculty members. They have done extremely today, and probably it will be much more helpful to them. So in concluding remarks, Santosh Singh, you say thank to all, and we'll have a goodbye.
Sir, it was a pleasure to be here with you all learned people. I have learned a lot from this webinar, and I am thankful to the IO and Dr. Vivek Trikha as such, and my mentor, Dr. Shivashankar sir. Thank you for so much. And I thanks to all the faculties. We will meet soon.
Okay.
Thank
Thank
you.
you.
Thank you. Bye bye.
शिव शंकर, ये जेट विमान है, प्राइवेट जेट है क्या?
Yes, yes, private jet है.
Yes, I will request Poonam to
एक घर
please
के अंदर ही
stop
पार्क
streaming.
करके रखा हूँ मैं. It won't fly.
बहुत अच्छा लगता है ये.
Yes.
OrthoDB, can we stop streaming, please?
शंकर
अभी जेट से निकल गया.
नहीं
घर के
निकल,
अंदर आ
अच्छा
गया.
निकल गए. Live streaming is still continued.
Yes, yes, it is continuing. So,
Okay.
Poonam,
Yes,
you are going-
Gadegone sir. I think we can exit ourselves. It will become automatically